to happen. There we go. And then we will get back in the practice of starting our public hearing. So welcome everyone to the second regular session of the 130th Legislature and the Health Coverage Insurance and Financial Services Committee. We have 4 public hearings on the docket for today, and we will begin as we always do with committee introductions, beginning with Representative Matheson. Go ahead.
Good morning, everybody. My name is Christy Matheson. I represent District 1, soon to be District 151, Kittery, the southernmost tip of Maine.
And Representative Arford.
Good morning, Madam Chair. My name is Representative Poppy Arford. I represent District 49, which is the western part of Brunswick.
Representative Evans.
Thank you, Madam Chair. My name is Representative Richard Evans. I represent the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Honorville Township, and Lakeview Plantation.
Representative Blyer.
Good morning, everyone. My name is Representative Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Representative Melrano.
Good morning. I'm Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and Livermore.
Senator Brenner.
Thank you so much, Madam Chair. My name is Stacey Brenner. I represent Senate District 30, which includes all of Gorham, most of Scarborough, and part of Buxton. And I'm really delighted to see all my HCIFS colleagues this morning. Happy New Year.
Representative Tepler.
Good morning, everyone, and Happy New Year. I am Denise Tepler. I represent House District number 54, which is all of the town of Topsom, and serve as co-chair of the committee.
Excellent. And I'm Senator Heather Sanborn. I represent half of Portland and half of Westbrook, and am thrilled to be here again with all of you to complete our work on some new bills and some carryover bills and some confirmations, all sorts of fun things that we will be undertaking in the next couple of months together. We will be assisted in our work, as always, by the unrivaled Colleen McCarthy-Reed and by our new clerk, Edna Cayford, who's going to do a fantastic job helping us keep things rolling behind the scenes. So without further ado, let me announce to everyone the plan for the day in terms of the order of operations. We are going to take LD 1783 out of order. We'll hear that last. That's a bill that I've sponsored, so I'll be turning the gavel over to my co-chair for that hearing. So we'll hear the other 3 first. So we will start with opening a public hearing on LD 1778, an act to improve healthcare affordability and increase options for comprehensive coverage for individuals and small businesses in Maine, sponsored by our very own Representative Evans. Go ahead, Representative.
Thank you, Madam Chair. Senator Sanborn, Representative Tepler, and esteemed colleagues of the Health Coverage Insurance and Financial Services Committee. I am Dr. Richard Evans, and I represent 7 communities in Piscataquis County. I am here today to introduce LD 1778, an act to improve healthcare affordability and increase options for comprehensive coverage for individuals and small businesses in Maine. As a physician and surgeon, I've always believed that health is the first wealth. Health is the first step in ensuring Mainers can pursue their careers, raise their families, engage with their communities, and otherwise lead the fulfilling lives they wish to live. Without access to affordable health care, families, communities, and our state as a whole suffers. Despite its importance, we know the impacts of unaffordable and inaccessible healthcare are getting worse, not better. According to a 2020 survey released by West Health and Maine Consumers for Affordable Healthcare, healthcare costs are going up for 3 out of 4 Maine families. And hundreds of thousands of Mainers have been unable to afford the care or prescription medications they need. Access to affordable health insurance is not just an issue of quality of life, it's an economic imperative. I think we can all agree that Maine's local small businesses and entrepreneurs are the backbone of our state's economy, especially in rural areas like the communities I represent. For those small businesses and entrepreneurs, the cost of healthcare is burdensome, and would-be entrepreneurs are held back from starting their own businesses by the difficulties accessing affordable care. LD 1778 directs our newly established Office of Affordable Healthcare, beginning in 2023, to analyze barriers to affordable healthcare for individuals and small businesses and develop proposals on potential methods to improve affordability and coverage. It directs the office to consider potential policies, including but not limited to the creation of a public option, a Medicaid buy-in program, increasing enrollment in Medicaid and CHIP, and providing state-level subsidies. Finally, it requires the office to report back to this committee with its findings and proposals. I know we share the same goal of ensuring Maine people are healthy and well and have access to the care they need. The Office of Affordable Healthcare is well positioned to take a comprehensive look at the best way we can achieve that goal. Not to be an alarmist, however, the last 2 years have demonstrated how fragile our healthcare system is. We have a moral and ethical obligation to do everything within our power to ensure that the public receives the best and least expensive healthcare as possible. We owe them nothing less. I thank you for your consideration and your time, and I would be happy to answer any questions if I can.
Thank you very much, Representative Evans. Are there questions for Representative Evans? All right, seeing none, we will take testimony in favor of the bill from members of the public who have signed up to testify. And the first person on my list appears not to be present.
I believe Senator Jackson signed up to
Oh,
testify.
you're right.
So let's
You're right.
bring him in first. Yeah.
Perfect.
Yeah.
Are you doing that, or do you want me to do that?
I can do
Okay,
that. I just
perfect.
did.
Awesome.
So I
Thank
tried to.
you
You're
for
welcome.
helping me.
Should be coming.
Yep. Good morning, President Jackson. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, members of Joint Standing Committee, Health Coverage Insurance, Financial Services. I am Senate President Troy Jackson. I have the honor of representing Northern Aroostook County in Senate District 1. I'm here today to testify in support of LD 1778 enact or improve healthcare affordability, increase options for comprehensive coverage for individuals and small businesses in Maine. Last session, we took a vital step toward ensuring that healthcare becomes a fundamental right for every Mainer. We established the Office of Affordable Healthcare. This office will be essential in helping the legislature take meaningful action to lower healthcare costs and expand coverage to everyone in the state. I firmly believe that nobody should have to lie awake at night wondering how much his or her medical care will cost them, or worry about how their children will pay for treatment of chronic conditions when they age out of family coverage. But that is the reality for far too many. 1 in 7 Mainers has gone without treatment or care because the costs were just too high. This office will identify the gaps in our system that prevent these folks from accessing coverage that would enable them to get the care they need without going broke in the process. The fact that this office has been established from the good work of this committee is a testament to how important affordable health care coverage is to every person on the committee. And LD 1778 will further ensure that the office gets help to the Mainers who need it most. This bill directs the office to figure out what barriers are preventing Mainers from getting health care that is affordable and propose practical solutions to the legislature. This will help us continue to do what our constituents sent us here to accomplish: improve health insurance and lower the cost of medical care. The bill also requires that the office study the impacts of policies passed by the legislature aimed at increasing affordability and access. This will provide future legislators with knowledge and feedback about whether or not our policies are working as intended, and give them the tools to refine policies over time so that they can continue to work for the people. You can feel like there's always a new fire to put out with healthcare regulation. The system is complicated so that it can be difficult to see where the problems truly lie and what solutions will work best to solve them. We need to carefully consider advice and planning from experts who understand what will help Mainers the most in need. LD 1778 is another step in that direction. Will give us vital understanding about how to make healthcare work for Mainers. I certainly want to thank you for your time. Certainly want to thank Dr. Evans for putting the bill forward. Happy to answer any questions.
Thank you, President Jackson. Are there questions for the Senate President? All right, seeing none, thank you for presenting testimony this morning. So as I mentioned, Megan Hannon is on my list, but I don't see that person in our meeting. So I will go to Hannah.
Senator Sanborn, oh, excuse
Yeah.
me. I do see Representative Collins is here, who is also co-sponsor. Do you know if he was intending to testify on this bill?
Representative Collins, if you wanted to testify on this bill, could you raise your hand for me? Okay, I don't see his hand up.
Okay. Just wanted to check.
Yeah, no, fair enough. It may be that he's here for a different bill. I'm not sure. Okay, so next, I think, and I can just go ahead and promote people because I'm looking at them in the list, Colleen. Next, I think we will hear from Hannah Hudson. So I'm promoting that person now.
Heather,
Is
Ben does have his hand up.
Oh, he does. I am sorry about that. I didn't see it go up. Okay, Ms. Hudson, if you would just wait for me for just a minute, I'm going to have our fellow legislator here go ahead of you, and I apologize. Representative Collins, go ahead.
Good morning. Thank you, Senator Sanborn, Representative Tepler, distinguished members of the committee. I'm Ben Collins. I'm a legislator in Portland. And I just wanted to quickly speak with you this morning, add my support for this bill. As some of you know, I was on this committee, which seemed like many, many years ago, but it was probably just a few years ago. And want to say hi to everyone and thank you for your work. It's a great committee that I miss being on. I do remember the tradition as well. Would we be in person? I'm supposed to bring chocolates and donuts. So the next time I see you, I hope I can do that. So I also remember being on this committee that we've had, I heard some of the testimony before me, and we had many talks similar. And as a matter of fact, we came up with a proposal to do some sort of study a few years ago because everyone on the committee from, representing every part of the state, different political parties, all agreed that the healthcare system wasn't working. We had some concerns about people being left out in Maine, and we wanted to look throughout the country, throughout the world, for ideas to see how we could improve the makeup of our healthcare system in Maine. There's been some efforts made federally and more specifically at the state level the past couple years that have made good strides to improve accessibility, to get more people healthcare, and I'm proud of the work we've all done. However, there still are tens of thousands of people that don't have all the healthcare they should be getting. And as we all know, in the pandemic, a lot of these issues have worsened. So I think it's a worthy cause. I think there are some programs that work, which we can expand. There are other areas we can study, which I think will go to great lengths to bringing some ideas back we all could consider in the near future to help make sure everyone has all the care, treatment, and whatever they might need holistically for health here in the state. So I want to thank Representative Dr. Evans for bringing this forward. I'd be happy to work with all of you on this. And, healthcare is one of the biggest issues you hear from anyone in any of our districts throughout the state, and it has been for years. The people want us to work on this, and I think this is something we can all roll up our sleeves and make happen. And thank you for your time.
Thank you, Representative Collings. Are there questions for Representative Collings? All right, seeing none, I apologize for not seeing your hand go up more swiftly, Representative, and thank you for joining us this morning.
Thank you, Senator. And it was my fault. I didn't know, I didn't hit the hand button. I just was raising my hand, but no one could see me. So sorry.
Yes, you were you were not visible to us. Perfect. Yeah. Thanks very much. All right. Now, Ms. Hudson, if you want to turn on your video and go ahead and present your testimony for the committee. Thank you for your patience.
No worries. Thank you very much. So Senator Sanborn, Representative Tepler, members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. I'm Hannah Hudson, Policy and Communications Manager at the Maine Primary Care Association. MPCA is a membership organization that includes all of Maine's 20 community health centers, CHCs. Maine's CHCs provide comprehensive medical, behavioral, and dental care for approximately 1 in 6 Maine people. CHCs make up the largest independent primary care network in the state, providing high-quality, wide-ranging healthcare services. They are at the forefront of delivering care to rural and underserved Maine communities and serve patients regardless of their health insurance status or ability to pay. MPCA supports LD 1778 and thanks Representative Evans and other co-sponsors for bringing this legislation forward. As an association whose mission is to ensure that accessible and affordable, high-quality healthcare is available for all Maine people, MPCA strongly supported the creation of the Office of Affordable Healthcare through legislation in the previous session. It is an important step to ensure that Maine policymakers have access to the best and latest information as they develop future healthcare policy for Maine. LD 1778 would expand the scope of the Office of Affordable Healthcare's work to focus on affordability barriers directly, requiring the office to study initially the effects of specific policies aimed at improving healthcare affordability and coverage. And it's important that we continue to focus on strategies to improve affordability, as access is critical for patients throughout the state, especially those in rural and underserved areas. Furthermore, CHCs are also small businesses that are struggling due to COVID. Efforts to improve healthcare affordability and coverage for small businesses can be a critical tool for recruitment and retention, and will be key to building a sustainable workforce moving forward. On behalf of Maine CHCs, we urge passage of 1778. Thank you for considering our comments.
Thank you very much for your testimony. Are there questions? All right, seeing none. Next, we will hear from Hillary Schneider. who I need to promote to panelist. Okay, perfect. She should be joining us shortly. Yep, there we go. Good morning, go ahead.
Good morning. Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I am Hillary Schneider. I'm the Regional Government Relations Director for the American Cancer Society Cancer Action Network. And on behalf of ACS Canada, I'd like to thank you for the opportunity to testify in support of LD 1778. As you likely know, one of the biggest worries a patient faces when they hear the life-altering words, "you have cancer," is how am I going to afford this diagnosis? In 2021, more than 10,000 Mainers were expected to be diagnosed with cancer. 1 in 2 men and 1 in 3 women are expected to be diagnosed with cancer in their lifetime. For these patients and their families, the costs associated with direct cancer care are staggering. In 2019, the national patient economic burden associated with cancer care was $21.09 billion, including direct patient out-of-pocket costs of $16.22 billion. As discussed in more detail in ACS Can's 2020 report on the cost of cancer, because of high costs, many people with cancer and those who have survived cancer experience financial hardship, including problems paying bills, depletion of savings, delaying or skipping needed medical care, and potential bankruptcy. Moreover, these costs and hardships do not impact all cancer patients equally. Patients who are younger, members of communities of color, those who have not yet obtained a high school education, and those with lower incomes are more likely to experience financial hardship. As such, it's not surprising that according to a nationally representative survey of cancer patients that we conducted last fall, 61% of cancer patients and survivors find it somewhat or very difficult to afford their care, and 37% say it's difficult to pay for the prescription drugs and treatments associated with their care. In my written testimony, I outline more details of that survey. We believe that patients need to be able to make decisions about their cancer treatment based on the best medical care for their diagnosis, not based on cost. It's unacceptable that some patients have to choose between treatment and paying rent or incurring huge amounts of debt. Based on clear evidence regarding the affordability challenges cancer patients face, we call on lawmakers and in Congress and in all state houses across the nation to pass policies that lessen cancer patients' financial toxicity and improve equitable access to the services and treatments necessary to save more lives from this disease. That's why we support amending the original statute that's set up the Office of Affordable Healthcare. We believe it's important to look at all the options. While we do not believe there's one silver bullet policy solution to reach the goal of all Americans having access to adequate, affordable healthcare, we welcome efforts to develop evidence-based policy proposals and the role that states like Maine have historically played in being incubators for developing innovative solutions. For these reasons, we urge you to vote to pass on LD 1778. Thank you.
Thank you, Ms. Schneider. Are there questions for Ms. Schneider? All right, seeing none, thank you for your testimony. Is there anyone else in our meeting who wishes to testify in favor of the bill 1778? If so, please raise your electronic hand. Aha, I see some hands going up. Okay, so I am promoting Kate Endy to a panelist so we can hear from her. Good morning. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage Insurance and Financial Services Committee. My name is Kate Endy, and I'm the Policy Director of Consumers for Affordable Health Care. Thank you for the opportunity to provide testimony in support of this bill today. CAIC is a nonpartisan, nonprofit organization that advocates for Maine people to be heard, respected, and well-served in a health system that provides coverage, access, and quality affordable care to all. As you know, we've been appointed by Maine's Attorney General as Maine's Consumer Assistance Program for Health Insurance. And as such, we operate a toll-free confidential helpline where we help field questions around eligibility, helping people to apply for and enroll in health coverage, including private and marketplace plans, as well as public insurance, and assist with other issues, either using insurance or accessing and affording care. It is our experience assisting Mainers navigating the healthcare and coverage systems that drives our support for this bill today. Too often we hear from people who aren't able to access the health coverage or medically necessary care they need, or who have gone into debt or experienced financial hardships in order to pay for needed treatment. Recent polling conducted by Healthcare Value Hub found that more than 3 out of 5 adults in Maine experienced healthcare affordability burdens in the past 12 months. Specifically, 63% of Mainers report experiencing one or more of the following burdens, either being uninsured due to high premium costs, delaying or foregoing healthcare due to cost, and or struggling to afford to pay medical bills. 55% of adults had delayed or foregone needed healthcare services, or had skipped or a prescription, or cut bills in half, or done other things in order to try and lower healthcare costs when for needed care. LD 1778 builds on legislation that was passed last session to create the Office of Affordable Healthcare, and it would help lay the groundwork for future policy initiatives to improve affordability of healthcare for Maine people and small businesses. The Office of Affordable Healthcare is charged with analyzing healthcare cost growth and spending trends, monitoring alternative payment models, and developing proposals for how to improve the cost-efficient provision of high-quality care and improve coordination, efficiency, and quality within the healthcare system, as well as providing staff to Maine's Prescription Drug Affordability Board. With this charge, the office is well positioned to help address many of the underlying cost drivers in our healthcare system, which is crucial to improving access to quality and affordable care in the long term. However, the best methods for improving efficiencies and addressing big picture cost drivers are not always on their own the most direct way of tackling certain affordability barriers that are faced by individuals and small businesses struggling to pay for healthcare and coverage. This bill would expand the scope of the office's work to focus on affordability barriers directly. It would initially direct the office to analyze and report back to the legislature on impacts of specific policies aimed at improving healthcare affordability and coverage, including creating a public option, health benefit plan, and Medicaid buy-in program, increasing enrollment in Medicaid and CHIP, as well as providing state-level subsidies to purchase insurance for populations that may not already qualify for federal subsidies, which could include working families stuck in the family glitch, for example. Beginning in 2023, the office would also continue on an ongoing basis to analyze barriers to affordable healthcare and coverage, and would include proposals on potential methods to improve affordability for individuals and small businesses in its reports to the governor and legislative oversight committee. As others have said before, there's no silver bullet to solving all healthcare affordability and cost barriers. However, we believe it's important to continue to strive to find policy solutions that will make it easier for people to access and pay for the care and coverage they need. And with that, I'm happy to answer any questions.
Thank you very much for your testimony. Are there any questions from the committee? All right, seeing none, the next hand I have raised is Pamela Corcoran. So I will bring her into the meeting. Good morning. There you go. Go ahead.
Thank you so much. Let me adjust to have a little better lighting here, perhaps. That's my hope. I'm going to ask my husband to adjust the windows in the back, and I'll start in respect for your time. Greetings, Chair Sanborn and Tepler, and honorable members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. Oh my goodness, let's try again. There we go, there's a little bit better. I think I'm a little visible now.
Much better, go ahead.
Okay, thank you. I'm so sorry. There we go. We brought in stage lighting. I'm Pamela Corcoran, a volunteer with AARP Maine. And AARP is the nation's largest nonprofit, nonpartisan organization dedicated to empowering Americans 50 and older to choose how they live as they age And on behalf of the 200,000 members statewide, thanks for the opportunity to share my testimony. I'm a resident of Belfast, and I am a current main care recipient due to the expansion option that was made available to me since 2019. Securing affordable healthcare coverage is critical to balancing my medical conditions and my 4 prescription drugs. I want to emphasize how essential it is to ensure that affordability remains forefront priority of consideration for older residents in our state. I am speaking in support of LD 1778, and I want to note that since the passage of the Affordable Care Act nearly 12 years ago, fewer older adults are uninsured and more are enrolled in non-group individual health insurance coverage, but many still struggle to afford that coverage, and they're very concerned about rising costs. A significant portion of older adults receive coverage through an employer plan. However, in 2019, over 31,000 older adults in Maine purchased coverage on their own in the non-group health insurance market. According to AARP's Public Policy Institute's report, Affordable Challenges for Older Adults in the Non-Group Market, from March of 2020, approximately half of the older adults in the non-group market had unaffordable healthcare coverage. And unaffordable is defined in that report as coverage with premiums that exceed 10% of household income or have out-of-pocket costs that exceed 7% of that income. Older adults in the non-group market are burdened by higher out-of-pocket costs than younger adults. Lack of affordable coverage can have harmful long-term effects. And of course, this includes individuals delaying or altogether foregoing care, and it can lead to higher rates of uninsured populations. Mainers need access to affordable healthcare coverage, and I respectfully urge support for LD 1778. Thanks for the opportunity to testify today. I'd be happy to answer any questions. I have submitted written testimony with detail and documentation on some of the numbers I've shared with you, but I hope you'll see my face and hear the personal story of how important, how literally life-saving affordability is. And I thank you.
Thank you for your testimony. Thanks for being with us today. Are there questions from the committee? All right, seeing none, thank you. Seeing no further hands for folks who wished to testify in favor of the bill, I'm going to switch to those who wish to testify in opposition to the bill, and we'll start with Ms. Pelletreau. Good morning, go ahead.
Good morning, everyone. Welcome back. Happy New Year. As you know, my name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. We do have one new member this year. It's United Health Group. So I now speak before you representing Aetna CVS Health, Anthem Blue Cross and Blue Shield, Cigna, Harvard Pilgrim Healthcare, Community Health Options, and United Health Group. Thank you for the opportunity. I'm speaking in opposition to this bill. The bill has 2 sections. The first is, directs the Office of Affordable Health Care to analyze barriers to affordable health care and coverage and to develop proposals for improvement. And Section 2 charges this Office of Affordable Health Care, which to my knowledge is not up and running yet. I believe that the appointments for the advisory board are just now being made, and I'm not aware of an executive director or staff that exists for that office yet. You'll recall, because you passed the legislation that established the office, what is already in their charge. It's quite expansive. I'm not going to list all the duties of the office, but they are expansive. LD 1778 proposes new undertakings for that office that again doesn't really exist yet, and requires the creation of new models of coverage before having the findings to support them. The office already has a lot to do under its current mandate. Its charge is correctly oriented, in our view, towards a better understanding of what's driving high healthcare costs in Maine. We believe that that is the right starting point that then will better inform future policy direction. We are supportive of efforts to better understand those underlying costs and the relationship between premiums, cost sharing, and enrollment. So our concerns are primarily with Section 2 of the bill. We do see that there's value to studying the impacts of policies that are intended to reduce costs and determine whether and to what extent they actually did and if there were unintended consequences. So thank you for the opportunity to present these comments. I'm happy to take any questions.
Thank you, Ms. Pelletreau. Are there any questions for Ms. Pelletreau? All right, seeing none, we thank you for joining us this morning. Next, we will hear from Chris Ossenfort, and I will promote her to panelist. Good morning. Go ahead.
Good morning. Thank you, Senator Sanborn. I had momentary heart failure because I mistakenly unplugged a cord on my computer just as you were calling on me. I was going to get my Zoom back, but it has resumed operations. So thank you, Senator Sanborn, Representative Tepler, and members of the committee. My name is Christine Ossenfort, and I am the Director of Government Relations for Anthem Blue Cross and Blue Shield here in Maine. And I appear before you this morning to testify in opposition to LD 1778. And as Ms. Pelletreau said, certainly we support looking at barriers to affordable health care. And we believe that much of this, what is proposed in the legislation, is already addressed in the existing statute. Section 3122, paragraph 3, subsection D, gives the office the authority to develop proposals for consideration on potential methods that improves the cost-effective provision of high-quality healthcare, which is largely what Section 2 aims to address. So the legislation doesn't expand the office's authority as much as it does direct it to consider certain proposals. I mean, we would suggest that if the legislature wishes to consider certain proposals, that the list should be more expansive and should also include looking at measures that would strengthen the existing health insurance marketplaces, both in the individual small group and large group markets, to evaluate the impact of clear choice plans and any merger of the market. And we would note that the focus should always be on healthcare costs. Because if we do not address healthcare costs, then it really doesn't matter who's paying the bills. It will continue to be unaffordable. So with that, I'd be happy to answer any questions that you might have. And of course, I'll be present at your work session as well.
Thank you, Ms. Ossenfort. Are there any questions? All right, seeing none, we thank you for your testimony. And next we'll hear from Bruce Garrity. Good morning, go ahead.
Good morning, Senator. Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity. I'm here on behalf of the Maine Auto Dealers Association. Now, I don't want to repeat comments that have already been made by Ms. Pelletreau and Ms. Ossenfort. I would point out that the Maine Automobile Dealers Association Trust, which is a MEWA, whom I'm representing today, has no profit motive. has its cost pared to a minimum. And the only thing it can't control are costs beyond negotiated rates with various providers. Again, without repeating everything that's been said, if one looks through section 3122, the focus is on providing alternative health care. And as Ms. Ossenfort said, cost is cost. And until you address cost, regardless of who is paying the bills are going to be high. Senator, I appreciate the opportunity. You've made these comments. I'd be happy to try and answer any questions the committee might have.
Thank you for your brevity, Mr. Garrity. Are there any questions for Mr. Garrity? All right, seeing none, we thank you for your testimony. I don't have anyone else signed up to testify. So if you did wish to speak with regard to LD 1778 today, please raise your electronic hand now. All right, seeing no electronic hands, I'm going to close the hearing on LD 1778, and we'll be scheduling that bill for a work session in the upcoming days or weeks. More news there soon. And so with that, I'm going to open a hearing on LD 1798 and invite Representative Millett to join us and give her testimony. I've been in the Senate too long, mispronouncing the representative's name. Good morning, Representative Millett. I apologize for my mispronunciation as I got started today. And please go ahead.
Senator, you know, I'll answer to hey you. I really don't care. So good morning, Senator Sanborn, Representative Tepler, and esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Rebecca Millett, and I represent House District 30, which is most of Cape Elizabeth. I am honored to present for your consideration LD 1798, an act to ensure health insurance coverage for adults with disabilities. LD 1798 requires state-regulated health insurance policies that offer coverage for a dependent child to cover adults with disabilities who are unable to sustain themselves through employment. As you know, we have a serious behavioral health crisis that is forcing families to take their children to emergency rooms, leaving them stranded there often for weeks and sometimes months. Just last week, Maine Medical Center shared with us that there are approximately 100 patients across the system awaiting discharge. In addition, we know Maine has a significant problem with waitlists and workforce for home and community-based services for adults with intellectual disabilities, autism, and acquired brain injury. This also creates significant barriers for all families trying to access behavioral health consultations. This legislation would provide Maine families with an important tool to help their children obtain critical supports and follow the lead of many other states in taking this approach. These states include Arizona, California, Florida, Georgia, Idaho, Illinois, Indiana, Massachusetts, Minnesota, Montana, Mississippi, Missouri, Nevada, New York, North Carolina, Ohio, Rhode Island, South Dakota, and Texas. Back in November of 2014, a Maine federal district court approved a settlement in a lawsuit filed by a group of adults diagnosed with intellectual disabilities and autism on a waitlist for Maine Care-funded home and community-based services. The settlement's terms required the Department of Health and Human Services to expand the waiver program and offer Maine Care HCBS to the approximately 1,000 class members before July 1, 2015. This was in response to the fact that people wait for many years for services. Maine consequently and briefly eliminated the waitlist for Section 29, quote, supports waiver by mid-2015. We've been unable to keep that promise, however, as the waitlist returned 3 years later. The legislature has allocated funds to address this problem in the past several budgets, but unfortunately, the waitlist was reported at 265 as of September 2021. The Section 18 Acquired Brain Injury Waiver Program also has a waitlist now grown to 148 individuals. Some of the people who do manage to get on Section 29 waiver actually need the more comprehensive Section 21 waiver, but that waitlist is even longer and currently at 1,968 individuals. Although LD 1798 could not provide the full suite of services offered by Section 21 waivers, it could provide at least some people some of the services that Section 21 covers, but that Section 29 does not, such as behavioral consultation, speech therapy maintenance, physical therapy maintenance, non-traditional communication consultation, and specialized medical equipment and supplies to people who meet eligibility criteria. And because insurance reimburses at higher rates than main care, people are more likely to find providers of some of these services accepting private health insurance than accepting main care. This legislation would also be a great help to families who do not qualify for waiver programs, but still have a critical need of treatment to address behavioral and communication challenges that may be core features of their dependents' disabilities. As you can see, the problems are significant and stubborn. I hope you will join me in supporting LD 1798 so that we may give Maine families just one more tool to access care and services for dependents who are adults with significant disabilities. Thank you for your consideration.
Thank you very much, Representative. Are there questions for the sponsor? Okay. Are there any co-sponsors in the meeting who wish to testify with regard to this bill? Please raise your electronic hand if that's you. All right, seeing none. And we thank you, Representative Millett, for your testimony. And we will, oh, I gotta go back to my list here. We'll next hear from Nancy Cronin, and I am promoting that person now. Good morning. Go ahead.
Good morning, Chairwoman Sanborn, Chairwoman Tepler, distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Nancy Cronin. I am the Executive Director of the Maine Developmental Disabilities Council, and I am in full support of LD 1798. Right now in Maine, there are over 2,400 adults with disabilities sitting on wait lists for needed services that would enable them to live full lives. These are all adults eligible for main care because of their respective disabilities, yet they are unable to get what they need. Every year, additional people with developmental disabilities leave high school at the age of 22 and are unable to access what they need as they are put on wait lists. In the DD field, we all call the experience of leaving public education and the children's system as the cliff. Some families may access some needed medical services through their health insurance. Unfortunately, many people sit on wait lists for well over 4 years without accessing the services they need. If families cannot access insurance, or when the child turns 26 and the child loses insurances, they fall into a chasm of little hope to no support until they find themselves able to access the services eventually, they hope, through waiver services. The time that they sit in the pit can be extensive. This bill would not provide all the needed services of a comprehensive waiver, but it would create a thin bridge between the two sides of the chasm, allowing for some medically necessary services to be covered through private insurance. Needed therapies that prevent complete regression could occur, as opposed to the individual slowly losing the skills they worked so hard to gain during their adolescence. In addition, this bill would provide broader, more equitable health access for people with disabilities. If passed, this bill might also decrease the funding burden on main care, as well as reduce the current reliance on more expensive care settings, such as emergency departments. This would be good not only for individuals with disabilities, but for the state at large. My only concern about this bill is how disability is defined as a person incapable of self-sustaining employment. I'm not sure what that means. It's very broad. I suggest that you amend the bill to consider being eligible for SSI or a different reason or a different method. But when I looked at the SSI eligibility, it did say that self-sustaining activities was a method of determining disability. So should that remain, it wouldn't be the end of the world. Anyway, thank you for reading this testimony, and I hope that you will fully support this bill. Thank you.
Thanks very much. Are there questions for Ms. Cronin? I have one, and you may not be the right person to answer this, but I'm trying to understand sort of the relationship with Medicare eligibility due to disability. And my understanding was that some adults with disability are eligible for Medicare. Can you help me understand the intersection of that and this bill?
A little.
Okay.
So it's not uncommon at all for a group of people with developmental disabilities to be considered dual eligibles. That's they're eligible for both Medicaid and Medicare, but that doesn't stop them from needing services for needing services that may not be available through because it's not because of the waiver issue. Even if you're a dual eligibles also sit on wait lists and wait for waivers as well. It doesn't shoot you up at a different level for these needed services. So basically, it gets you into main care, or it gets you into the additional level of Medicare, but it doesn't necessarily get you what this would. And I'm going to leave somebody else to answer more thoroughly.
Okay, I'll ask more questions about that of others that might come later as well. And certainly something I need to understand better because I don't understand it right now, just to be clear. Are there other members of the committee who have questions? All right, we thank you for your testimony and thanks for helping us try and understand the issues at stake for sure for adults with developmental disabilities. Okay, next we will hear from Alan Koba-Lewis. And I am bringing that person in now. Whoops, I think I got the wrong person. Hang on just a minute. I brought in Mr. Yardley accidentally because he jumped to the top of my list suddenly. Mr. Yardley, I'm going to send you back. Okay. Good morning.
Good morning,
Go
Senator
ahead.
Sanborn. Good morning, Senator Sanborn, Senator Tepler, distinguished members of the committee. My name is Alan Koba-Lewis. I live here in Orono, testifying for the bill. Maine, like the rest of the U.S., has a mixed public-private system for getting people health insurance coverage. With that in mind, 40 states covering 87% of the U.S. population. You can see figure 1 of the map by testimony shows those states. It requires state-regulated individual and/or group health insurance. Some states are a subset of those, but for the most part, it's pretty comprehensive. Require individual and/or group health insurance policies that cover dependents to offer coverage to dependents who are adults with significant disabilities. The detail is in table 2 with links to the state statutes. These states range from the very red, Texas and Mississippi, to the very blue, California and Massachusetts. There seems to be wide bipartisan agreement across most of the country that this sort of coverage is an important tool for families. In addition, major self-insured employers, including in Maine, that are not state regulated, frequently offer such coverage. The coverage is also important enough that it's offered to military families through TRICARE insurance. But state-regulated insurance in a minority of states, 10 states, including Maine, is not required to offer coverage to dependents who are adults with disabilities past age 26, the Obamacare limit. And yet the coverage is important enough that even in some states that don't require state-regulated private insurance to offer such coverage, it is offered to state employees. New Hampshire does that. Maine also does that. The bill can help address the workforce and waitlist crises, the dual crises of people with significant disabilities eligible for Maine care that have plagued Maine for several years. So, for example, some adults with disabilities who really need comprehensive services through the Maine Care Section 21 comprehensive waiver for adults with intellectual disabilities or autism. It's not enough to be Maine Care eligible. You have to then get onto the waiver. The waiver has a wait list even if you're already covered by Maine Care, Maine's Medicaid service program. The wait list is almost 2,000 people long for the comprehensive waiver. Some of those folks are waiting years for the 21 waiver while they get a lower level of service from the Section 29 supports waiver. And some people get no support while on the wait list for Section 29, which is another 265 people long, or on the wait list for the Section 18 brain injury services waiver, 148 people long, or on the smaller wait list for the Section 20 other related services waiver. These are all waivers that you need to qualify for on top of being admitted to Maine Care based on your disability. People who need the comprehensive support through Section 21, the comprehensive waiver, but who are only getting more limited support through 29, while on the 21 waitlist, aren't able to access the services that Section 29 doesn't provide. This includes behavioral consultation, speech therapy maintenance, physical therapy maintenance, non-traditional communication consultation, and some specialized medical equipment and supplies. If adults with significant disabilities could get additional health insurance through a policy covering the family, then some of them could get at least some of their needs for these services met while spending years and years on the wait list for the comprehensive 21 services. In addition, even folks who are not on the wait list, but who are actually covered by the waiver, they can't always get their needs met on the waiver. Essentially, private health insurance reimburses providers at much higher rates than Maine Care does. Consequently, some professionals don't accept Maine Care, or they limit the number of people in their practice on Maine Care. Getting access to additional private health insurance coverage could help some Maine Care recipients, including those who are not on wait lists but who still can't get their needs met, get more of the health care they need. Finally, under state and federal law, Maine Care is supposed to be secondary insurance. In other words, if someone has private health insurance plus Maine Care, the private health insurance is expected to pay first, provided the service is covered by the private health insurance policy, understanding that in particular, the waiver services will cover a broader array of services than private health insurance will. This gives Maine Care the opportunity to use third-party liability to reduce Maine Care expenditures and consequently reduce the burden on the state general fund for people whose families take advantage of the opportunity to access private health insurance coverage. I therefore suggest that if the committee chooses to move forward on this bill, and I would request that you do vote on to pass, that it amend the bill, or perhaps ask the HHS committee to consider companion legislation, requiring Maine DHHS to explore the cost effectiveness of creating monetary incentives for families to elect such private health insurance coverage, with the goal of such incentives being more than offset by reduced Maine Care expenditures through third-party liability. And I have a couple of other suggestions based on what I've heard from the testimony today from Ms. Cronin and some of the written testimony that I saw posted online. I guess they are Ms. Cronin and I think Ms. Williams might be coming up, or I think she has written testimony, suggested changing the bill's reference to self-sustaining employment to maybe something coming out of SSI law. SSI basically says they talk about being unable to engage in sustainable gainful activity. That seems like a reasonable amendment to me. I think the intention is not that you can't work if you have a disability, but that you can't work enough to basically get access to the employer health insurance market that other folks get. So sustainable gainful activity sounds like a reasonable substitution to me anyways. I think that the insurance commissioner is going to suggest clarifying that this doesn't apply to self-insured plans which are not seg-regulated. Sounds perfectly reasonable to me. And last, I did note that there was some written testimony by a couple of parents. I don't know if they're going to testify in person or not, but both of them, Mr. Johnson and Ms. McDermott, comments basically were excited about dental coverage in particular. I know that my understanding is that main care coverage has been expanded to include dental. I've definitely had the experience in my family when my son, who's on the 21 waiver, and who does have private health insurance coverage, basically having a lot of difficulty getting a dentist because main care rates were so low that they limited the number of main care of folks they would accept. If the committee chooses to move forward on the bill, if you want to consider adding dental to the to what's covered, I would certainly welcome a change like that, which I think might address what Ms. McDermott and Mr. Johnson were hoping for. I think the bill is worthwhile even without that, but I would certainly suggest that the committee consider that as well. Please vote out to pass, give Maine families the same tool that residents of 40 other states already have to address healthcare needs of adult dependents with disabilities. Thank you very much. I'll be happy to answer any questions that you have.
Thank you, Mr. Koval-Lewis. We did have a question from one of our committee members about whether you represent an organization or whether you're just testifying on behalf of yourself. I'm
testifying on behalf of myself. Basically, my son is on the 21 waiver and essentially has an unstaffed 21 waiver. He's a victim of the workforce crisis, and private health insurance has been a godsend for my family. It has not replaced waiver services, but it has been a godsend, and I would really like other families to have access to the same tools.
Thank you. And my second question is with regard to how these adult dependents are treated in the plans that already have this offer of coverage. Is it that you buy family coverage? So if you had other children, for example, your premiums wouldn't go up. They would just, this additional dependent would be included in the premium?
Yes, if you had other children, your premiums wouldn't go up. If you didn't have other children, you have to pay, for family coverage.
Yeah. Okay. I thought that was the way it worked, but I wasn't positive. Okay, great. That's helpful. Did you have any insight for me in understanding? Is it that private insurance covers much more than Medicare does? Is that why this is important?
Right. I mean, I think you mean main care, right? So whether private health insurance covers more than Medicaid?
No, my question was about federal disability and whether the same individuals were eligible for coverage under Medicare because of their disability for health insurance.
So I can't directly speak to Medicare because essentially I'm coming from my own family experience. I have a son who's covered by main care, Medicaid, as well as my employer's insurance because of his disability. What I can say is that in general, the waiver services will cover more than private health insurance. Although there is this issue of if you're in the smaller waiver, there's a gap. And some of those services covered by the smaller that are not covered by the smaller waiver, but the bigger waiver. Behavioral consult's the big one. There's a few others. Some of those might be at least partially covered by private health insurance. I think really the big issue is that the main care reimbursement rates are so low that I guess the two issues are if you're on a wait list, then you really then main care's coverage actually falls short. But the other issue is that even if you're not on the wait list, the main care reimbursement rates are so low. This is why dental is a particular issue that you don't have meaningful access to the care. Private health insurance won't cover as much, but they will cover some of it. And for the part that they do cover, they pay so much more that it's easier to find a provider.
Understood. Thank you. Representative Arford.
Yeah, thank you so much for testifying before us today. I have just a couple of questions. I'm trying to understand the whole picture here. And so I understand that you have at least one child who's receiving main care services and also private insurance and has either turned 26 or is about to turn 26? Is that correct?
I mean, he's actually 21, and to be honest, to be frank, he would not be helped by this bill because my employer is an example of an employer with a self-funded plan that already covers past age 26. This is really about seeing how important this is for our family, and I don't know that we're going to need it past age 26. If he eventually transitions to a group home, this may be a non-issue. This is really about essentially transition to adulthood. And so, how far past age 26, essentially transition to adulthood might be more extended past age 26 for some people with significant disabilities. So it's really about, like Ms. Cronin mentioned, about the thin bridge across the chasm when you're trying to transition. If you have somebody basically living at home who's not yet funded or able to access a comprehensive other setting, so that they're not without any services and seeing themselves regress, while waiting for work from the
Right. I didn't want to focus on your personal situation. What I'm trying to understand is just an example of a service that anybody transitioning from at age 26 off of their family-based private insurance, that if they were also on main care, that at that point, I'm talking about a medical service, a behavioral health service, because those are the services that have been mentioned that we're speaking about here. One that would not then be picked up by main care and covered by main care.
Well, the behavioral services are ostensibly covered by main care, but you can't always find a provider. So the issues are, if you're on a wait list for the comprehensive waiver, main care will in fact not cover it, because it's not enough to get main care. You have to have main care and get on to and be accepted onto the waiver. And essentially, if there aren't enough state dollars to fund the waiver, you sit on a wait list for the waiver. And then once you do get off the wait list and actually get access to waiver services, if main care doesn't pay enough, you can't find enough providers. Not every behavior analyst will provide the service because the reimbursement rates for the behavior analyst is so much lower than market, whereas the private health insurance is paying market rates.
Thank you. Thank you very much.
All right, thank you for your testimony. And I don't have anyone else signed up to testify verbally in favor of the bill. So if there is anyone else who wishes to testify in favor of the bill, please raise your electronic hand at this time and we'll pull you into the meeting. All right. Seeing no hands go up, we will shift to those testifying against the bill, and I will bring in Bruce Garrity once again. Good morning, Mr. Garrity. Go ahead.
Good morning, Senator. Thank you for giving me the opportunity to speak on this legislation. Senator Sanborn, Representative Tepler, and members of the committee, my name is Bruce Garrity. I'm here again on behalf of the Maine Automobile Dealers Association, MEWA, which, as you know, is a self-insured trust that provides some 6,000 members of the association with healthcare coverage. Very briefly, first, the Maine Auto Dealers Association already provides coverage for those over 26 who have, pardon me, a disability, and they periodically do require information from an insured regarding the continuing nature of the disability. I understand that most, if not all, plans in Maine handle the matter similarly. So I think one thing the committee should consider is there a need for the bill, or is this issue already being addressed? If it is, then I would submit that one always has the issue of unintended consequences or problems that haven't been anticipated and don't need to be potentially created. And I'll give you an example of this in this legislation of one of the concerns that we have. It's listed in several places. I would point to page 2, line 11, that references self-sustaining employment. I don't think that definition is at all clear, and I'm not sure it has any guardrails. As such, I think it is, again, the kind of language that can create problems down the road. What I'd also add is that it seems to me, from the testimony that I heard from the proponents, the big problem seems to be access, not coverage. To the extent that's the case, as we all know, the committee has acted to broaden the general scope of telehealth based upon each professional's licensing board addressing that issue. And I submit that to the extent there's an access issue, this bill really doesn't help in that regard either. And Senator, I'd be happy to try and answer any questions the committee might have.
Thank you, Mr. Garrity. Mr. Garrity, I do have a question, which is that you represented that the Maine Auto Dealers Association already provides this coverage for adults with disabilities. Can you provide to the committee, either right now or in writing after the hearing, what language the Maine Auto Dealers uses to, in place of the self-sustaining employment language that you object to, so that we could get that standard more in line with what your practice is as a trust?
I appreciate your question, Senator. Let me try to answer that right now. The language in our coverage is in 2 parts, and I'll just read it, and I can provide it to the committee in writing afterwards. It references an unmarried child of the subscriber or the subscriber's spouse or domestic partner, who, as of the date the child turns age 26 or older, and I think this is the key language, or part of the key language, is mentally or physically unable to earn his or her own living and is chiefly financially dependent on the subscriber. The section goes on to say, a child who is eligible as a dependent because of a qualified medical support order or other court or administrative order requiring medical coverage for a child of a subscriber or spouse or domestic partner of a subscriber, such child will be eligible for medical coverage as stated in the QMSO. And again, that's qualified medical support order. And that essentially requires a judgment, decree, or order issued by a court or administrative agency.
Okay,
so
thank you. Has that
language.
standard proved workable for your trust?
We believe it is. We've not had complaints from members, but we do think that this section and our ongoing coverage for those over 26 works.
Great. Okay, I'm trying to understand why your organization would be against other Mainers having access to this type of offer of coverage. And if it's just that the standard we've used in the bill is the wrong language, that's fixable. So is there something beyond the standard of coverage in the bill being incorrect that causes you to be against other Mainers having access to the same coverage that your members have?
Well, first, if I can just clarify our position, Senator, we're certainly not against other Mainers having this kind of coverage. I think our point is more that, as I understand it, this kind of coverage is already being provided. Assuming that's my understanding, assuming that's accurate, then I would suggest it isn't necessary. And when you start putting in legislation that is redundant or unnecessary, I just think you open the door to problems down the road that might not be anticipated. That's not to say that the point of this legislation isn't meritorious. We recognize that by our own program.
Okay, that's very helpful. Thank you very much. And I know there are others coming after you who represent other insurers, and we can ask what the practice is. So I appreciate that. Thanks very much. Are there any other questions for Mr. Garrity? Okay, seeing none, we thank you for your testimony, and I will now offer anyone else in our meeting who wishes to testify in opposition to the bill to please raise their electronic hand at this time. And seeing none, we'll go on to those who have signed up to testify neither for nor against the bill, and we'll start with Catherine Pelletreau. And let me find her in my list and bring her into the meeting. Good morning, Ms. Pelletreau again. Go ahead.
Senator Sanborn, Representative Tepler, members of the committee, my name is Catherine Pelletreau. I speak today for the Maine Association of Health Plans, and I do not have written prepared testimony. I reached out to the sponsor and our member plans to understand what this bill was getting at, and frankly, I'm not sure I 100% get it, even after having listened to all that testimony. I will say that our plans pretty much provide this coverage. In fact, the language that I have from a different plan is exactly the same as what Mr. Garrity read. So I think that basically exists, but there are some policy considerations that I think that the committee needs to consider. For one thing, whether somebody might be eligible for Medicaid coverage, which, as you've heard, is broader coverage than what private insurance covers. Whether somebody might be eligible for subsidies on the exchange if they have some employment, but it is not sufficient to fully support them. It could be that they could buy their own coverage on the exchange and qualify for substantial subsidies. So, you know, not sure that as a state of Maine, we want to leave those dollars on the table if people do qualify for them. I would also note, and you've heard it from proponents already, that this is clearly a cost shift. I mean, we're talking about a community rated pool where a family purchases a family policy. And although the rate may vary if you're buying for an individual or an individual and a dependent, and a dependent, or an individual and more than one dependent, it's not as if each member of the family is rated separately. You know, it's rated as a policy as part of the community rated pool. So I think that's something that the committee also needs to grapple with a little bit. So I think I'll stop there. And I will try to put our thoughts together in writing for you, but I wanted to take the opportunity at least to respond a little bit today in person and to take any questions that the committee might have.
Thank you, Ms. Pelletreau. Representative Tepler, go ahead.
Thank you very much, Madam Chair, and thank you for being here, Ms. Pelletreau. Ms. Pelletreau, you used the word pretty much, and I guess those were the words that I was most concerned about, because I think we are talking about a narrow group here of folks who are falling between the cracks, and your words pretty much made me think, well, maybe there is something here. Can you expand on that possibility?
Yes, for sure. The only reason I said that is because I didn't hear back from all 6 of my plans. So I think it's 4 that I heard back from that did provide that coverage. So that's really the only reason. I would hope that, I've asked, and it sounds like it is typical across most of the industry. So if I hear something different from them, those last 2 that they don't cover it, then certainly that's information I would share with the committee. But that's what I meant, not that the companies that were providing the coverage were providing inadequate coverage.
Go ahead.
follow up. Thank you. I just want to say that I do hope you will provide us with the complete information from all your plans, because I have a feeling this bill came from somewhere. And so I'm curious where that hole is.
Mhm. I'd also be interested to hear if there's a specific plan that the advocates know isn't covering this. But my understanding is it's pretty typical to cover it.
Thanks, Ms. Pelletreau. And I would note that it does appear to be the law in 40 states. So that might be why the big national insurers are covering it. But I'm not sure that's a great argument for why we shouldn't also join them in requiring it as a legal matter. So I would appreciate your written testimony as a follow-up, because what I'm trying to understand is you pointed out a couple of potential unintended consequences or side effects in terms of maybe it would be a better idea to use Medicaid, or maybe it would be a better idea financially to buy insurance on the individual market. By passing this bill, are we putting people into a family glitch? Are we doing something different than what the insurers are already doing by offering the coverage? Because my understanding is this is merely a mandated offer of coverage, as opposed to that the family has to take the coverage or has to pay for the coverage if there's some other financially more advantageous arrangement out there. So I'm a bit baffled by your arguments because they don't seem to apply. So if you could help us out with some more written testimony that might help us understand that would be really helpful.
I absolutely will. I did hear one of the advocates suggest an amendment that would incentivize people to move off of Medicaid or subsidized coverage onto private plans. So I think we'll also take some issue with that. We don't think that makes good policy sense.
Okay. My understanding is there are some of those incentives already for those families that can afford private coverage.
We don't love those. Yeah.
Main care would be secondary. Okay. Representative Matheson, did you have a question? Okay. All right. Seeing no further hands raised, we thank you for your testimony. And next we'll hear from Chris Ossenfort.
Good morning, Senator Sanborn, Representative Tepler, and members of the committee. My name is Chris Ossenfort. I am the Director of Government Relations for Anthem Blue Cross and Blue Shield, and I'm testifying neither for nor against LD 1798. As other speakers have indicated, the need for the legislation is not clear. Most plans do cover this today. We do cover if someone is on the plan and turns 26 and they are disabled, they can continue to stay on the plan, and that is true for both our individual and our group plans. And our definition is actually fairly close to the statute. It says those who cannot work to support themselves by reason of intellectual or physical impairment is our individual market definition. It is important to note that this is just a mandated offer, which means it would be the employer's decision whether this coverage was available, not the employee's decision. So it would not necessarily increase access to this coverage. It could actually restrict it. Because it is part of our plans today, but mandated offer means the employer chooses whether or not that is included in the employer-sponsored plan. So you could actually limit the availability of that coverage today. We would have concerns about the proposal to create financial incentives. Individual policies can already be purchased if someone chooses to do so. And I did want to just clarify how premiums are determined. In the group plans, the premiums are family, it's employee, and spouse/partner, employee plus child, employee plus, family plan, children. That's not how the individual market is priced, however. Individual market under the ACA is per member rating. So you pay for the adults on the plan, you pay for the oldest 3 children up to age 21 and all children over age 21. So it does affect an individual's premium. So with that, I'd be happy. And of course, noted, putting this in Maine law would not require self-funded plans to extend this coverage to their employees. So with that, I'd be happy to answer any questions, and we'll of course be at your work session as well.
Thank you, Ms. Ossenford. Are there questions? Okay, I have one. I'm super baffled by what you said about mandated offer means the employer decides whether it's offered. I mean, the Affordable Care Act mandated that children between the age of 21 and 26 be offered coverage as dependents. That's not up to the employer. It's a mandated offer. How would this be any different than that?
Because mandated offer means we have to offer to the policyholder, the employer, the ability to cover any employee's dependents over age 26 who are disabled. It's their choice whether or not to include mandated offer coverage. I'm trying to think if there aren't too many mandated offers on the books these days. I think there's one for cardiac rehab of certain levels, which means we offer to the employer group, the decision maker, do you want to include this coverage in your policy? And they can say yes or no. And then it either goes into the certificates, which each employee has, or it doesn't.
I'm still baffled by that. Is that not how you would treat? I mean, the Affordable Care Act mandates coverage of age 21 to 26. So
right, but we're talking about older.
We're talking about over 26. But I'm trying to understand how we could get it such that the employer would have to offer it. They don't have to pay for it, but they have
that
to
would be a
offer
mandated benefit, which we then would go to the Bureau for study.
Mandated benefit. Okay, we're going to have to lean on Colleen to understand the distinction here, because this seems to be an offer of coverage rather than a particular type of benefit.
Right.
So I don't think
it's a requirement that the coverage be offered, not that the coverage be provided, if that makes sense.
Okay, we'll definitely look into this more. Representative Matheson.
Yes, thank you so much, Madam Chair. I'm having a really hard time understanding a few things, but I'm going to ask 2 questions. My first question is, if most of the plans already offer this, why are you against this being in policy?
I'm testifying neither for nor against, saying we don't see it.
Okay, great. And also, if most plans do cover this, why is this a problem then with constituents? That's where I'm getting lost. Clearly, there must be some challenges in the definition of someone actually being eligible for this coverage, because there's obviously something happening where constituents are not able to continue this coverage. That's why this is being brought up. So I guess that's where I'm getting a little lost. If this coverage is offered.
It's hard to say. We do offer it. They could work for a self-funded employer that chooses not to provide such coverage. I think a lot of the testimony also focused on wait list issues and the ability of Medicaid eligible individuals to actually be able to get the services they need, which is a different issue than whether or not they have.
Yeah, no, I understand that. That's not
Right.
that's
they
not
can
my
buy.
question.
I mean, even if an employer didn't include this coverage, if someone wanted to buy an individual plan for their child, they could today.
Right, but it seems to me that there's a problem with that, even though it exists there for coverage. And I guess what I'm trying to get at is, what is that problem in trying to access that plan coverage? I'm just not sure.
Yeah, I will go back and look at the testimony. I don't recall anybody saying that they had trouble getting private coverage for this. But I'll look at some of the testimony that's been submitted.
Representative Tepler.
Thank you, Madam Chair. And Ms. Ossenford, these questions really aren't for you. They're more for our analyst for our work session. I guess I just really want to know if there are insurers in Maine, carriers that don't currently offer this coverage. For example, carriers that aren't working in those states that have this as law. And I'd also like to know if in those states that do have this as law, there have been any issues for in terms of extreme cost difference that have been noted by the state, or other concerns that we should be thinking about.
Okay, those weren't questions for Ms. Ossenfort, so I think we'll just move on. Representative Brooks.
This is a question that I'm hoping that you'd be able to help us understand either now or at the work session, and also for other people listening. So if somebody was eligible, a young adult, and it was referred to as a cliff, like from going from the education system to adulthood, that transition period, to help eliminate that gap in services, what is our best approach? And I understand that it's multifactorial, and there's a divide between private insurance and public insurance as far as the cost and the cost sharing, as well as the individual and family that's going through the difficulties. So for the individual and families, if they're eligible for primary private insurance, and that is also more favorable for reimbursement for providers, or maybe that's what they'll accept, and that's another problem or issue. How can we bridge that gap so that the services can continue without that big gap, and what's our best approach is my main question.
So there's a lot wrapped up into that. I'll try to parse it out. I think that because, at least as Ms. Belger under 4 carriers do allow somebody to stay on the plan past age 26 if they are disabled. So there is no gap in that instance if they want to keep them on. Individual policies can also be purchased for that individual if they want the duplicate coverage. I think the issues for main care reimbursement, the obvious answer is we need to increase main care reimbursement as a state to, one, encourage more providers to take main care. The waivers I'm less familiar with, the wait lists for those, whether it's provider availability, I'm not sure, but obviously that's a main care issue, not a private insurance issue. But if someone wants to purchase a plan or keep someone on the plan, they can do that today, pending, they're rising to the top of the wait list.
Okay. Representative Brooks, can I lower your hand? Is that it? Okay. Okay, great. All right, we thank you for your testimony, Ms. Ossenfort. I know there were some tough questions there that might not be totally within your wheelhouse, so appreciate that. And next, I am going to bring in Superintendent Chapa, who is also signed up to testify neither for nor against. Good morning, Superintendent, go ahead.
Good morning, Senator Sanborn, members of the committee. I am here today to testify neither for or against LD 1798. This emergency bill would require insurers offering health plans for a dependent child to cover dependent adults with disabilities who are incapable of sustaining employment. We really only have 2 comments. One has already been covered, the definition of self-employment. If you're going with that, we think it should be defined in the bill. The other is the language in this bill is phrased as an exception to carrier's obligation to cover dependent children under age 26. If it is intended to be an exception to a carrier's right to terminate coverage at age 26, the committee may want to consider amending the bill. And finally, we, as several speakers have mentioned, we don't have authority over self-insured plans. And with that, I'll be happy to answer any questions. And if you'd like, I can we can bring suggested language to the work session.
Thank you, Superintendent. I'm wondering if your suggestion that we relocate the language or reframe it as a provision about termination solves the mandated offer issue that Ms. Ossenfort seems to have brought up, which suggested that somehow the employer would have to choose whether to offer this type of coverage or not. That just doesn't seem like what this statute says. Can you help us understand that piece?
I probably have to talk to my attorney. It's
okay. That's fine. The other thing I wanted, just in listening to your testimony or reading your testimony, I think this is a bit more than just an offer or a restriction on the ability to terminate coverage, because I'm thinking of the person who gets a new job just when their adult dependent child is 28, let's say, and they're going to need an offer of coverage, not just the forbearance of termination of coverage for the new plan to enroll the dependent adult child.
right.
Does that sound right?
Yeah, you'd want it to be an offer, not an exception. Right.
Right. Okay, so we might need both, or maybe we need to leave it drafted as it is.
Again, I know I have two attorneys listening to this bill, and they're hearing your question.
Perfect.
Right.
I will wait for their response, and they can work with our analysts to help us understand that piece, but I appreciate you bringing up the issue. Are there any additional questions for the superintendent? All right, seeing none, thank you for providing us with your insight on this and look forward to working with you to further understand the bill. Are there any other individuals in our Zoom meeting who wish to testify either in any capacity with regard to this bill? If so, please raise your hand at this time. All right, seeing none, I'm going to close the hearing on LD 1798. And I think we will at this point just take a 5-minute break or so. Is that how I want to do this? We might take lunch now, actually, and come back and do the other two bills after lunch. Just as I'm looking, I think it's going to be another, probably hour and a half or so. So that's probably too much to get done before we take a lunch break. So, so I guess at this point, I'm going to propose to the committee that we take a lunch break. I know a number of folks are needing to testify in another committee at a hearing that starts at noon. So I am going to propose that we come back at 1 p.m. and finish up the last two hearings. Normally, I wouldn't give us such a long lunch break, but knowing that we've got some folks with a conflict around noon, it seems like a good opportunity for us to give them an hour to testify and then be able to pop back in. How's that sound, everybody? Okay, great. So with that, we'll go on break until 1 p.m. and we'll see you back here then. Thanks, everyone.
Interesting cocktail dress. $65. Wait, how about is the back zip? No. Bâton.
Just looking for one more member of the committee so we can get started. I think we probably technically could get started because we hadn't adjourned, but yeah, I was counting you too. I figured you were there. Thank you. I just would like to have 7 if we can. Before we get started back up. Here we go. Perfect. Okay. So with that, we are going to continue our public hearings for this afternoon. We have 2 bills left. And the first of those that we're going to pick up is LD 1822, an act to improve access to behavioral health services by prohibiting cost sharing by insurers. And someone already pulled her in. Is that what happened? Looking for the sponsor. Oh, there she is. She raised her hand. So went to the top of the list. I don't seem to be a co-host anymore because I had to leave and rejoin. So if somebody could make me a co-host, I can move Representative Morales into the meeting.
I moved her in, so I'm still authorized.
Wonderful. And in the meantime, if our clerk could make me a co-host again, that would be super.
We're doing it right now, Senator.
Wonderful. Thank you so much. That was
You're welcome.
Forgotten about. It's been a minute since we were here doing this. So Representative Morales, thank you for joining us, and please proceed with your testimony.
Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and esteemed members of the Health Coverage Insurance and Financial Services Committee. My name is Victoria Morales, and I represent South Portland in House District 33. And I come before you today to present LD 822, a policy to improve healthcare affordability and utilization for preventative behavioral health services by prohibiting the imposition of cost sharing by insurers. The reason for this policy is to achieve the following results. First, Maine people with insurance who need preventative behavioral health care for mental health and substance use disorders will be able to access those services because they won't cost them an additional $500 to $4,000 of out-of-pocket expenses for the necessary treatment. Given that half of Maine households, approximately 500,000 households, we have approximately 500,000 households in Maine, so approximately 250,000 households are at or below area median income, which is about $55,000 per year. These costs are a barrier to access. And second, the state marketplace will see an increase in Maine people choosing to purchase policies because these plans will be more affordable due to the reduced out-of-pocket expenses. The urgent need for greater access to behavioral health services is not in dispute here in Maine or across the country. Mental health and substance use disorders are the leading cause of disease in the United States, and the United States has the highest mortality rate for these disorders among similarly wealthy countries, and Maine is unfortunately not exceptional in this regard. Overdose fatalities in Maine have tripled over the pandemic to a point where we are losing 12 Maine people a week to this disease. Maine Commissioner of the Department of Corrections, Randall Liberty, has stated numerous times that the majority of the residents of the Department of Corrections and those being supervised in the community by the department, including all of the children under the care of the department, suffer from untreated behavioral health disorders. According to a recent study in JAMA Pediatrics, Maine has the highest percentage of mental health disorders for children in the country, with 1 in 4 children in Maine having at least one mental health disorder like depression, anxiety, or ADHD. According to Sheila Nelson, Program Manager for the Adolescent Health and Injury and Suicide Prevention at the Maine CDC, we've been seeing this is a quote, we've actually been seeing a worsening in young people's mental well-being for quite a number of years, even before COVID. In Maine, suicide was the second leading cause of death for Maine young people between 10 and 24 before COVID, and the numbers have only risen during the pandemic. And if you speak with any teacher, guidance counselor, school social worker, school administrator, which I know you all do, they will tell you that the number of students suffering from mental health crises and using substances to cope is worse now during the pandemic than they have ever seen it, and they do not have the resources to help. National studies show that the unaffordability of health insurance is a key contributor to the disparities in access to mental health and substance use disorder services for Black, Brown, and Indigenous communities. And cost sharing provisions do prevent people from accessing necessary behavioral health services, which is why the long existing Medicare and Medicaid programs were designed to remove most of these cost sharing provisions based on this data and research that has existed for many years. Beyond the health necessity, which I think most of us agree on, there is a cost necessity. Improving access to mental health and substance misuse services is much more cost effective than to allow behavioral health disorders to go untreated. The specific reductions in overall costs anticipated from this policy will be seen in the form of a reduction in emergency room utilizations, in patient hospital stays, in early intervention in childhood, in preventions of child welfare services for parents and children, and the prevention of ongoing issues for young people into adulthood, in the prevention of the deterioration of mental health over time with accessible treatment, which will prevent not only mental health and substance use crises and overdose, but importantly, multiple comorbidities, chronic conditions that accompany the failure to treat behavioral health disorders, for example, schizophrenia. Maine's January 2022 report, it just came out on the current cost of our most costly emergency services, emergency rooms, psychiatric hospitals, jails, for those experiencing long-term homelessness, of which 100% experience behavioral health disorders, states that prevention in the form of behavioral health services and housing greatly reduces the utilization and cost of the deep end of the healthcare system. The report states that emergency room costs per day are at $1,000, not including ambulance and paramedic services or hospitalizations thereafter. Psychiatric residential placements are at $3,073 per day, and jails cost about $903 per day. Although the focus of this 2022 report is to link housing with behavioral health services to solve homelessness, notably for the purposes of this bill, the report states that at a mere cost of $2,400 per year per individual with severe and persistent mental illness for behavioral health services, the utilization of our crisis systems will likely significantly decrease. As for the costs associated with the racial disparities, according to a 2003 to 2006 study by the Joint Center for Political and Economic Studies, eliminating racial and ethnic health disparities for behavioral health services would have reduced direct medical care costs by $229 billion nationwide in those years. For reference, as you are considering this bill, I also want to share with you that the state of New Mexico passed this policy, the policy proposed in this bill last year, and came to the same conclusions articulated in the rationale for this policy. According to the fiscal note analysis for New Mexico's SB 317, the New Mexico Office of Superintendent of Insurance reported that, quote, the legislation anticipates that eliminating cost sharing for all behavioral health services will result in increased access to and utilization of these services. The increased use of services would then lead to improved adherence to behavioral health treatment regimens, including medication use. The bill anticipates that improved adherence to treatments will improve outcomes and results in lower healthcare costs, particularly costs for emergency room and inpatient hospital admissions. In addition, a large percentage of individuals with behavioral health conditions have high rates of co-occurring chronic health conditions such as diabetes, hypertension, and COPD. Studies show that these illnesses, which are costly to treat to begin with, can be 3 times more costly to treat when the individual has a comorbid behavioral health condition. Therefore, improved access to behavioral health services could reduce the overall cost of healthcare, end quote. I thank you all very much for the opportunity to present this policy, and I look forward to working with you to improve healthcare affordability and accessibility for Maine people. Thank you.
Thank you, Representative Morales. Are there questions for the bill sponsor? Representative Morales, do you know if there are other states that, I think you mentioned New Mexico, are there any other states that have done this?
Colorado, I was just reading in the National Conference of State Legislatures, and it looks like, and I put it in a footnote to what I submitted, Colorado, New Jersey, and New Mexico, it's in footnote 3, are reported in NCSL as establishing some of these policies, and it goes along, this is one of the policies that's recommended by NCSL.
Okay, thanks. I don't see your written testimony in our online submissions. There's no attachment with your sign up. So if you could go ahead and resubmit that through the portal, that would be great.
It's actually just further down for Representative Morales is listed twice. So if you look down through the written testimony, I think you'll see it. I see it on mine.
That's funny. I don't. I
She's
reloaded it a
about
couple
halfway
times.
down the list, like 3
Oh,
or 4
you're
from the
right.
bottom.
Yep,
Yeah.
I
Okay.
just didn't see it.
Good.
Okay, perfect.
Good.
Never mind, Representative Morales. I was looking right at it. And thank you for the footnotes. I'll take a look at those. Appreciate it. Representative Bleier.
Thank you, Madam Chair. Representative Morales, you made a comment that I'm curious on. You said that the homeless have a pretty much 100% mental illness, and I'm wondering how this bill would help them.
Yeah, I thanks for the question, Representative Bleier. And I only referenced that report because it talks about the cost of the utilization of these deep end portions of our system. Not that this bill is to solve chronic homelessness. So my apologies if I didn't make that super clear. But my only point was to raise that this is how much it costs in the deepest end of our system when we don't prevent behavioral health disorders. So it's
Representative
not
Brooks. Oh, sorry. I didn't mean to interrupt you. Go ahead.
No, sorry. I'm finished. Thank you.
Okay. Representative Brooks.
Yes, I had a question for Representative Morales. I appreciate your bringing this bill to our attention, and I think it's really, really critical that prevention is worth, it's worth its weight in gold, really. And it's all so interrelated. One thing I found through my life and different things that with medicine, it's so intricately involved. The brain is part of the body, and the body's part of the brain. Then our basic needs are so necessary as well. With the question and things for us to look into more even than the comprehensive overview is that cost of emergency rooms, that cost of emergent care, homelessness, prisons, juvenile justice is a big passion of mine as well. And how do we prevent these things? How do we divert these things? How do we rehabilitate the conditions of people, human beings? And it's just really interesting as well. Not interesting like a warped way, I guess, but a lot of medical illness, like you mentioned COPD, for example, with breathing problems, oxygen, just to the common people, oxygen's a good thing. Too much oxygen in COPD can be a dangerous thing. And one of the first manifestations is a mental status change or infections. There are so many intricacies involved and also the behavioral health services. And I'll get to a question, but it is something to consider. That small barrier, whether it's even $5, if people don't have the $5 for a copay, they don't have the $5 for an office visit or transportation. They don't have that continuity of care. They don't have that encouragement to go seek other help in restoring function. And I thank you for bringing this to our attention.
Thank you, Representative.
Are there any other questions for the sponsor? Okay. Seeing none, let me relaunch my list here. We thank you for joining us today and for bringing this bill forward, Representative Morales. Next, we'll hear from Jonathan Sarbeck. Good afternoon, and go ahead. You're on mute, so we're not able to hear you.
I'm sorry, I had to leave my office to attend the opening of Freedom Place, so I'm on the cold streets of Portland right now. For those of you that don't know me, my name is Jonathan Sarbeck. I'm the district attorney here in Cumberland County. I am not an expert when it comes to healthcare law, but I can tell you that in the criminal justice system, which I do consider myself an expert in, we have many people who are suffering from substance use disorder and mental health issues. And any type of barrier that is created that limits their ability to get treatment is something that really can be detrimental to public health and public safety. And I support LD 1822 and appreciate Representative Morales bringing it forward because this would limit, or I should say, decrease the barriers that are very important to people seeking this type of behavioral health care. That's going to be very vital to their health, and if you can reduce the chances of them coming into the criminal justice system and also emergency rooms, the financial burdens that are going to be put on our community. So I would ask that the committee vote ought to pass on this legislation, and I'd be happy to answer any questions for you.
Thank you, Mr.
Also,
Satterbeck.
I did give some written testimony if anybody needs to take a look at that.
I do see that in our records, so thank you for that. And I don't see any hands up on our committee, so we'll let you get back inside where it's warm. Right. It's awfully cold out today.
Yes,
so
it is. Thank you very much,
us.
everybody. All right, take care.
Okay. Next, we'll hear from Betsy Sweet.
Hi, Senator Sanborn and Representative Templer and wonderful members of this committee. Thank you so much. My name is Betsy Sweet, and I am here in support of LD 1822 on behalf of Behavioral Health Community Collaborative. This is some of the largest agencies. Together, we serve about 70% of people who receive behavioral health services in Maine. And I have written testimony that will be put in your portal after this is done. Representative Morales gave extraordinary testimony and covered most of the points that I wanted to say. But I just want to say, in the behavioral health world, with the exception of, even with Medicaid and Medicare, as Representative Brooks mentioned, a small copay, but in private insurance in particular, the copays and especially the deductibles often prove to be a concrete barrier for people receiving behavioral health services. And just for an example, I want you to think about, for many, many people, their deductible is $7,000 a year, $5,000, $6,000 a year. And just think, if you're going to and a lot of the people that are being seen or need to be seen are young people. Often they don't have other big health expenses. So if you are looking at getting support for your child or for your teenager, if you have that kind of deductible, a $5,000 deductible, and let's just say, for the sake of math, that your visits are $100 an hour or $100 a visit, you would have to spend 50 weeks to even get to the deductible on that policy. So there really isn't even any insurance, let alone help for that. So it's really a huge barrier, particularly for private pay people, but for everybody. And so, and as Representative Morales and Jonathan said before, the long-term costs of this are not just for the individual, because those are significant, but they are for all the other services that you do such a good job of providing in our jails, in our schools, in our emergency rooms. Right now, behavioral health is one of the most significant problems that we have, and you will hear from us a lot this session. We have a lot of proposals on how we can get rid of the thousands and thousands of people on the wait list for outpatient therapy, thousands of people, young people waiting for residential treatment. I mean, we're in a crisis when it comes to behavioral health, and access is the biggest part of that crisis. Part of it's on the supply end, and we will be, as I said, we'll be talking to you more about that, and part of it is on the access end because of the financial constraints. In addition to doing my advocacy, I also have a counseling and coaching practice, and I can't tell you how many people say, oh my gosh, I can't, I would love to come. I really need to come. My child really needs to come. And I always accommodate those people, but they say, I can't do it because, I can't afford the copay. And I always make accommodations for that. But many practitioners are not able to do that. And so it's a huge issue. This would go a long way, again, to preventing further, much more high costs down the line, and it would start to give relief. And this was a problem before the pandemic, but right now, with the pandemic, there are just thousands and thousands of more people who are needing to access behavioral health services, and this would be a huge way to help provide some of that access more easily. So I'm, as I said, Representative Morales covered everything else really well, and so if there's any other questions, I'd be more than happy to answer.
Are there any questions for Ms. Sweet? All right, seeing none, we thank you for providing your testimony today. Looks nice and sunny and warm where you are in contrast with your predecessor. All right, thank you. Is there anyone else in our meeting who wished to testify in favor of the bill? If so, at this time, please raise your electronic hand. Seeing no hands raised, we will shift over to those who wish to testify in opposition to the bill, and we'll hear first from Elizabeth Frazier.
Hello.
Good afternoon. We can go ahead.
Fantastic, thank you. I was redirected right as I thought you started to say my name. So I was like, well, I guess I'm up. Hi, everyone. Good to see you. Senator Sanborn, Representative Tepler, and honorable members of the Health Coverage, Insurance, and Financial Services Committee. My name is Elizabeth Frazier. I'm an attorney at Pierce Atwood, but I am before you today on behalf of the Maine Jobs Council. I am testifying in opposition to LD 1822. Just to give you a little bit of background about the Maine Jobs Council, because they are new. They are a relatively new statewide, nonpartisan, member-driven advocacy organization that works to advance public policies that support foundational jobs in Maine. And one of the things that they believe is critical to advancing and growing those foundational jobs is to find a way to ensure that health coverage is affordable for all Mainers, for both employers and employees. We know that high health coverage premiums can substantially reduce the growth or startup capability of entrepreneurs and small businesses. And these are the employers that provide backbone jobs for the state of Maine. Our focus is therefore on lowering health insurance premiums across the board. And so as a general matter, MJC does not support legislation that could lead to an increase in premiums without an offsetting action. And I'll just say that we do recognize and appreciate the intent of this legislation. Certainly, you know, under the current circumstances that we're all in with COVID-19, recognizing that there's been an increase in the need for behavioral health services. And just to sort of re-articulate that the position comes more from the hope that in aggregate, the state won't adopt too many policies that lead to health coverage premiums increases. So with that, I will also just let you know that I'm hoping to submit some additional comments in writing after the fact, but I did submit some written testimony about an hour or so ago. So hopefully you have that, but I will get you some more as well for the work session. And I'd be happy to take any questions.
Thank you, Ms. Frazier. We do have your testimony, so that's helpful.
Great.
Are there questions? All right, I don't see any, so we will move forward.
Thank you so much.
Thank you. Next, we'll hear from Catherine Pelletreau.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I speak today for the Maine Association of Health Plans in opposition to this bill. We oppose this bill because it's going to raise the cost of health insurance for all purchasers. As you know, and you've heard us talk about before, we are generally supportive of increased access to primary care, to behavioral health care, for quality of life reasons, as well as avoiding costly specialty care and medications. However, while we understand the importance of removing barriers to accessing treatment, there needs to be acknowledgement of the associated increase in costs. This state and this committee has done a lot in this area recently. Going back to the 129th legislature, the legislature passed LD 2007 that had provisions for coverage without cost sharing for the first primary and behavioral health visits each year. And further, no deductible coinsurance may be applied to the second or third primary care or behavioral health visits during a plan year. So any copays applied for those visits must count towards the deductible. That law also requires the superintendent of insurance to analyze the effects of these changes on premiums based on experience in plan years 2020 and 2021 and report back to you. In addition to LD 2007, health plans have also done, to 2000, LD 2007, but also because of the COVID pandemic. I mean, health plans have done a lot to accelerate their telehealth offerings. And a major part of this is access to behavioral healthcare services, and often without copays. Those newer tools are intended to help people get access to treatment. So while cost is certainly a challenge, and that is what this bill primarily, I think, seeks to address, the out-of-pocket cost for users of behavioral healthcare services, we also see a fairly severe shortage of providers in the state of Maine. So using the new telehealth tools at health plans tries to address both of those factors. The Bureau also, as I think you followed fairly closely, has worked very hard to develop clear choice plans that work well for consumers, so address consumer concerns that necessarily conform with LD 2007 and necessarily conform with federal actuarial value requirements. So the 2022 Clear Choice plans designate copays of between $20 and $50, with silver plans at $30. If this bill is enacted, it would be impossible to reach a bronze medal level actuarial value, and possibly difficult to meet silver AV as well. So we're concerned that if this does pass, it's going to leave a marketplace with predominantly gold level plans which have premiums that are out of reach for many participants or purchasers in the market. So from a policy perspective, it's really hard to pick and choose who should pay more, who should pay less. What services should have higher copays? What services should have lesser copays? So if you were to eliminate copays for behavioral health services, you would necessarily be increasing, those monies would have to come from somewhere. So is it fair to ask people who are getting knee surgery, who have cancer treatment, who have heart diagnoses, problems, for them to pay higher out-of-pocket costs to accommodate the lower out-of-pocket or elimination of out-of-pocket expense for behavioral health care? So our suggestion is that the committee recognize what's already being done, see the results of what is already being done, and what the impacts of those policy changes that are already in place are, before moving forward with a bill like this that can have a quite potentially extreme impact on the health insurance marketplace. I'm happy to take any questions. Thank you.
Thank you very much, Ms. Pelletreau. We appreciate your input on this. Are there any questions for Ms. Pelletreau? All right, seeing none, we thank you for joining us. I'm going to bring in Ms. Ossenfort.
Thank you, Senator Sanborn, Representative Tepler, members of the committee. My name is Christine Ossenfort. I'm the Government Relations Director for Anthem Blue Cross and Blue Shield in Maine, and I appear before you to testify in opposition to 1822 I will just briefly reiterate Ms. Pelletro's comments. Our concerns are primarily that this would result in a significant increase in premiums to require first dollar coverage of behavioral health services. And it would be at the expense of other benefits covered under the plan because we have to maintain actuarial value. So if we are required to provide first dollar coverage for behavioral health, then cost sharing for other services is going to have to increase in order to maintain AV and to try to keep the plans as affordable as possible. So while well-intended, we strongly urge you to vote ought not to pass, and I'd be happy to answer any questions that you may have, and we'll be at your work session as well.
Representative Tepler.
Thank you, Madam Chair, and thank you for being here, Ms. Hostenford. Ms. Hostenford, can you just talk for a minute about how parity works and whether co-pays for other conditions, physical conditions, recognizing that physical and mental is a divide that may not be real, but how the co-pays work under the parity system?
Sure. So there's a whole factor of, a whole set of factors that go in, not just what the cost sharing is, but there's quantitative and qualitative analysis that go into determining whether or not a plan complies with mental health parity. But the essence of it is that behavioral health has to be treated on par with medical. You can't treat medical more favorably than behavioral health. They have to be somewhat equivalent. And so there are a variety of reasons that sometimes the behavioral health cost shares may be lower than primary care in order to maintain parity. But this would go far beyond parity and would actually create favorable treatment of behavioral health at the expense of medical, other medical services.
So just to follow up 1 second, if I may, Madam Chair. So can you give me an example of co-pays for a behavioral health visit and a physical health visit at, say, let's just say the silver level of a plan?
Off the top of my head, I cannot. I'd be happy to bring that back to you for the work session.
Okay, I think it would be helpful to have some charts to look at comparative cost sharing for physical and mental health diagnoses.
Great. Ms. Hostenford, I have some questions that I want to take in a slightly different direction, but that are related to this bill. We've heard from a number of folks, and I expect we may hear again from Mr. Garrity shortly, that the issue really here is about supply and about ensuring that we actually have the healthcare professionals that we need to provide behavioral health. And that has certainly been my experience with regard to my own family and with regard to my staff members who have sought these kind of treatment and found long wait lists or large barriers. So as you're aware, because we've gone back and forth over the last 6 months, part of this appears to be related to credentialing and network arrangements by our insurers. So one of my observations has been that newly to Maine counselors or folks that have newly received their credentials as counselors or folks that are doing apprenticeship as counselors are not able to take on patients in a prompt manner because the credentialing process can take months and months and months. And I have specific examples of this with regard to a constituent who runs a mental health practice. Can you speak to what Anthem is doing to ensure that credentialing is fast-tracked in the mental health arena?
Yeah, so as Senator Sanborn mentioned, we did encounter some delays in credentialing providers, and it was for sort of a number of factors. We had a little bit of a perfect storm, but one of the issues was we, like everybody else, have faced some resource and staffing issues during the pandemic. The other is we saw an uptick, particularly seeming to impact behavioral health providers because as they moved to telehealth and started seeing patients remotely, perhaps from home, they had to submit basically a change of address form that we call a provider maintenance form. Those sort of two, we also had somebody retire, somebody out on maternity leave, so contributing to our staffing issues. So we did have a backlog of credentialing and provider maintenance forms that seem to just have a significant impact on behavioral health providers. We have been dedicating resources and working to get that backlog addressed. And we're not there yet, but we have made significant progress in getting those providers credentialed or getting those system updates incorporated so that we have the right address and the right billing information for those providers. It's something that we will now be aware of and watch for going forward to make sure that it doesn't start to reappear. But we have definitely prioritized getting those providers credentialed and getting those updates processed.
So, and you may need to check with folks on this, but if I were managing a mental health practice, behavioral health practice right now, and I hired a new counselor who just moved here from New York, fully licensed, ready to go, how long would it take before I could bill for his or her services through Anthem?
I'll have to check at Rule 850. There is a requirement that we process within a certain amount, or if we're missing information that we tell them within a certain amount of time. I want to say it's 90 days, but I will have to confirm that. The legislature did also pass a statute a few years ago that allows providers to bill for patients that they are seeing while their credentialing application is pending, as long as they claims until the application is complete. So they are able to bill for services that once they submit the credentialing application, but the process should take no more than 90 days.
Okay. And the risk lays with the practice manager that person, that the credentialing might drag on for a longer time than that, and the bills might go unpaid for a longer period, or perhaps forever if the person was somehow rejected. Is that right? Or is it a ministerial practice, or is there a substantive review of whether you're going to approve a new counselor?
There is a review. We do have to verify credentials. For some providers, we have to verify hospital admitting privileges. Those are requirements under 850 as well. Sometimes we have encountered delays in getting that, obviously, and not necessarily limited to behavioral health, or hospitals have been very busy lately. So their ability to respond to our requests for verification of credentials or verification of admitting privileges is also been impacted. I'm not sure I would say that the risk lies with them. Certainly, if the provider is denied credentialing, then those claims would be considered as out-of-network claims and would be processed as out-of-network claims under the plan.
Okay. My second area of questions for you with regard to behavioral health is another thing that we were made aware of in the off season here was with regard to sort of an auditing of behavioral health providers' billing practices and what's been referred to me as algorithmic downcoding of mental health services that were provided through main practitioners and should have been paid for by Anthem at a higher level of severity, requiring additional resources from the behavioral health practice in order to try and appeal those algorithmic downcodes. Can you speak to that practice and whether it's continuing with regard to mental health services?
So no, it is not. We did have a program to review to make sure that claims are being coded at the appropriate level. And we did find that behavioral health claims were in fact being coded appropriately. And so they have been, well, the program has been suspended. But when the program is resumed, behavioral health will not be part of it.
Okay, I appreciate that. And I do appreciate, I wanted the committee kind of know about that and the exchange that you and I had. And I did appreciate your responsiveness in providing that information to me in the interim. So thank you. Thanks for allowing us to grill you again on these topics and for providing this important information related to mental health care in Maine. access certainly is an issue that we need to continue to press forward on. Are there any other questions for Ms. Ossenport? All right, seeing none, we will bring in Mr. Garrity. Good afternoon, go ahead.
Good afternoon, Senator. Senator Sanborn, Representative Tepler, and members of the committee. My name is Bruce Garrity. I'm again testifying on behalf of the Maine Automobile Dealers Association Insurance Trust. I won't repeat everything everyone else has said. I was going to raise the point that you anticipated I would raise, Senator, so I don't need to say it again. It is a matter of cost. We do think it's going to have an impact that would permeate all the other coverages. And the only other point I would make, in reading the testimony that's been submitted, but not followed up on by direct testimony today, the HSA issue looks like a pretty significant issue to address. And my understanding is that has created some significant difficulties in New Mexico as well. I can't testify about it further, but I just wanted to bring that point to the committee's attention, and I appreciate the opportunity to have testified and would be happy to answer any questions the committee might have.
Thank you, Mr. Garrity. Representative Tepler.
Thank you again. And Madam Chair, and thank you for being here, Mr. Garrity. And I guess I would just like to make sure that for the work session, we have some information about that issue around HSAs, both from the carriers of concern and from Ms. McCarthy-Reed.
I understand, Representative.
Thank you.
Now, I'll just direct the committee's attention to a letter that we received actually in our email. I don't believe that it was submitted as written testimony, but I could be incorrect. That was from Kathy Boris related to this from a bank perspective on the HSA issue. So if you didn't see that in your email, definitely reference that for the committee's review related to HSAs. Representative Brooks.
Thank you, Chair. Mr. Garrity, you may or may not be in a unique position to be able to help provide this information, and others for the work session would be welcome to bring this type of information. But I see the potential for huge savings when it comes to prevention and early diagnosis and treatment, so that if we were able to cut off perhaps a barrier to treatment for behavioral health or mental health manifesting illnesses, that we would save a lot of money in extensive ER times, extensive admissions with difficulty with discharge. And I don't know if the population might be a little bit more, perhaps, I don't know if you have any data to that respect.
Excuse me.
Bless you.
Let me respond a couple of ways, Representative. First, with all due respect to those who have raised that point of view, it's one that we believe is a hopeful statement by those who support it, but won't necessarily bear out in reality. I have asked the actuaries for the trust for their assessment on this issue. I have not heard back. Assuming that I do get something before the work session, I will certainly pass it on to the committee, and thank you for the question.
All right, are there any other questions for Mr. Garrity? All right, seeing none, we thank you for joining us today and for providing your testimony. Is there anyone else in our Zoom meeting who wishes to testify in opposition to the bill? Please raise your electronic hand at this time. Seeing no hands go up, I will bring in our Superintendent of Insurance to talk neither for nor against. Superintendent Chapel, welcome to our meeting, and please go ahead.
Thank you, Senator Sanborn. I had a little mouse difficulty there for a second. I won't read my testimony. I'll just summarize it and add further information if that's okay.
Sure.
I mean, our testimony, we mentioned premiums, but we don't have an estimate of the impact of this would have on premiums. And we wonder, you know, as deserving as mental health benefits are and access to mental health, you know, there could be other equally conditions that would benefit from such treatment as well. And how do you, and I wouldn't want to be the one who had to decide which treatments get this or not. But in regard to New Mexico, I wasn't aware of the New Mexico study. We'll reach out to New Mexico and try and get some information as to how they've arrived at that determination. And in terms of mental health parity, we are doing a market conduct exam. We're starting a series of them. We're starting with Anthem to determine compliance with mental health parity law. Now, we just started the exam, so it'll be a while, but I want the committee to be aware of that as well. And as part of that market conduct exam, we're going to look at provider payment issues as well. So that's just additional information. I can answer any questions.
Thanks very much. I wonder if provider credentialing is part of the parity issue as well.
We can look at that.
That would be helpful, because I know at least with regard to a different carrier, one of the mental health counseling programs in or practices in Portland was told that their provider panel was full and that they didn't need any more counselors. This was many months ago, and they reopened it after some pushback from a state senator. But the idea that there would be this level of inadequate access to mental health, but no more room for more providers in the credentialing panel was quite worrisome to me.
I have not heard that before. Yeah, that's an interesting assertion.
Yep. So anyway, as you're conducting those audits, I'd love to have that in-network credentialing be part of the conversation as well.
Mm-hmm.
So thanks for that. Representative Arford, go ahead.
Yeah, I just want to follow up on the bill, the very comparatively to this bill, which is a much more robust bill regarding reducing out-of-pocket costs for behavioral health services that we addressed, that I had submitted last session. And we sent you a letter asking that you review this when you were looking at the next go around of clear choice plans. And I'm just wondering if you have done that, or when you would be doing that, or if you have anything to report to us about that, or any comments to make, because that was brought up as an issue with this bill as well.
I can check the status of that, but we've had a couple rounds of clear choice meetings. I think you attended the last round. We're really beginning the process, and I'll check with Marty Hooper as to the status of that particular request. I don't know off the top of my head, quite honestly.
Thank you very much, and thank you for your testimony.
Mm-hmm.
You're welcome.
Are there any additional questions? I have one more, which is, I'm sorry, Representative Brooks, do you have one? Go ahead.
I had a question just about like doing a strict cost analysis. And we've seen a lot of things with the coronavirus pandemic. One of them being, I don't know how to put it, but like a shift in prioritization and urgency and emergency when it comes to some infectious and pandemic related illnesses. So I think that, you know, we all have a lot of knowledge, real life experience with the coronavirus pandemic as far as what we've experienced. And from the Bureau of Insurance perspective, there have been a lot of other experience that you've been privy to and that you've helped establish. And this, I think, is an opportunity for savings and for learning in motion as well. Like, for example, I guess where I'm going and what I'd like your feedback on is, one thing we saw was that it seemed as though with elective surgeries and things like, for example, I know people that have knee issues that have postponed knee operations until the pandemic subsides and have more conservative measures in place until perhaps that happens, we hope, and vaccines and things like that. So I think there had been like a savings for plans in that regard. So getting back to the point of behavioral health and emergency room visits and comparing the two, are you able to do more of a broad analysis as far as assessing how something like a behavioral health visit could help in a number of ways, almost like an employee assistance program, or something that would help enable a person to break a barrier of going down and assessing why they might be feeling somewhat anxious about a current event or something. I mean, it could be any range of subjects that people go to a behavioral health person for, but I don't know if you have any insight on those wide strokes.
I think that it sounds that New Mexico did something similar to that, and I think I'm going to defer the question till we can contact New Mexico. I mean, it sounds like, costs. How do they avoid? Arrive the conclusion that this money avoids costs later on. So hopefully, they'll have some insights, because no, we have not. We don't have the data on that at this point in time.
Thank you, Superintendent. And yeah, with regard to following up with New Mexico, it sounds like this is the first plan year. So there have been plans for sale for 11 days, or in effect for 11 days with the new law in place. So I'd be interested to know what happened to premiums in the 2022 plan year in New Mexico, and also how they're achieving actuarial value on those plans. So.
Yeah.
That'll be really interesting for you to be able to hopefully bring us some insight on that. It'll be very early insight, I understand, but some insight.
The value question is interesting. I don't know how they did it, but we'll find out.
Perfect. Great. Well, thank you for joining us and for those follow-up pieces that you'll bring back to the committee. And this one might need a couple of work sessions so that we can hear those report backs and then ponder things further. So appreciate that. Are there any additional questions? All right, seeing none, I'll do a last call for anyone else in the Zoom meeting who wishes to testify in any capacity with regard to LD 1822. And seeing no hands go up, I will close the public hearing with regard to 1822, and we'll be scheduling a work session in the future on this bill. All right, so with that, I think it would be great if we could take a 5-minute break just so that I can stand up. It's been an hour since we started here. And then we'll come back and hear the last bill with Representative Tepler at the helm. All right, so we'll be back at 2 o'clock exact. Thanks.
think we'll wait for a few more folks to come back. Josh and Mark, are you with us? Thank you. Thank you. And Heidi? Well, hopefully she'll rejoin us shortly. Good afternoon, everyone, and welcome back again to the Health Coverage Insurance and Financial Services Committee. We are about to open a hearing on 1783, our last bill of the day for public hearing. And this bill is sponsored by our own Senator Heather Sanborn. So I will invite Senator Sanborn to present her testimony and introduce us to her bill.
Thanks so much, Representative Tepler. Okay. So Representative Tepler and honorable colleagues, as you know, I'm before you today to introduce LD 1783, an act to require health insurance carriers and pharmacy benefit managers to appropriately account for cost-sharing amounts paid on behalf of insureds. As members of this committee are keenly aware, prescription drugs can be outrageously expensive. This is often true for the most serious chronic diseases that people can face, which require extensive, ongoing maintenance medication. We've all heard firsthand of the extraordinary financial strain this sort of treatment can put on patients and their families. Out of necessity, those who are facing down thousands of dollars of medication each month often seek help paying for their prescriptions. Fortunately, some folks are able to qualify for copay assistance programs from the drug manufacturer or from a third party that provides some limited financial help. This is good news and a welcome relief until one day they realize that their insurer has implemented a relatively new innovation known euphemistically as a copay accumulator program. These programs mean that the copay assistance funds that they used to afford their medication won't count toward their deductible or out-of-pocket maximum, saddling patients with additional out-of-pocket costs that offset the benefit of the copay assistance. These patients now have to miraculously come up with the money that they weren't planning for, money they didn't have to begin with, which is what led them to find help paying in the first place. If they can find the money to continue treatment, it will likely be by making sacrifices in other parts of their life, like food or heat. If they can't, they could be forced to stop treatment. Copay accumulator programs essentially double bill people for their prescriptions. The money that patients received and used to help them afford medication is accepted without issue, and then they're told that the money from a third party isn't the same as if it came out of their own pocket. This is wrong and it's bad practice that hurts patients and provides them with no benefit. We have to put an end to it. You'll likely hear that these programs are an important cost-saving tool, but there are provisions in this bill, and I think they could be even further strengthened after reading some of the testimony that was submitted last night in opposition to this bill. But there are provisions here to make sure that these copay assistance programs don't become big pharma's end run around formularies, but instead truly provide copay assistance to the folks who need it. Copay assistance programs, or the applicability of those copay assistance programs to out-of-pocket costs, are already in the bill text, limited to only drugs for which there's no generic equivalent. And we could further extend that exception to drugs for which there is an appropriate brand name substitution as well, that would be lower cost, so that we can use copay assistance programs for the purpose that they were intended for, which is to help people pay for their medication, rather than forcing folks into this situation where they're still required to pay the full out-of-pocket cost, perhaps just later in the year. With that, I urge you to pass this bill, and I would be happy to take any questions that you might have.
Are there any questions from the committee for the sponsor? Seeing none, thank you, Madam Chair, for your testimony. And I'll now turn to those who wish to testify in favor. I don't see any legislators wishing to testify in favor, so I will move to my list and ask Colleen to please bring in Angelica Katz.
Hi, everyone. Thank you. Can you hear me okay?
Yes, we can. Thank you.
Great. Hi, Senator Sanborn, Representative Tepler, and members of the Healthcare and Insurance and Financial Services Committee. My name is Angelica Katz, and I am the Northeast Regional Manager of State Policy and Advocacy at Susan G. Komen. I'm here today to offer testimony in support of LD 1783, as we believe this legislation is critical in reducing cost barriers to care for our patients in Maine and will ensure all expenses made by or on behalf of a patient count toward their cost sharing requirements and insurers. Komen is the world's leading nonprofit breast cancer organization representing the millions of people who have been diagnosed with breast cancer, and we advocate on behalf of the estimated 1,430 people in Maine who were diagnosed with breast cancer and more than 190 who died from this disease in 2021. So recently, many health insurers and pharmacy benefit managers have instituted copay accumulator programs, which prevent copay assistance from counting towards a patient's cost sharing requirements. Unfortunately, this creates a significant financial strain and delay in healthcare treatment for patients. These accumulator programs are harmful to patients because most do not even know about the program until it's too late, and then they're hit with a big bill for hundreds or thousands of dollars in prescription costs, as Senator Sanborn had mentioned earlier. You may also hear today or have heard that copay assistance steers patients from generic to brand name drugs, but according to a recent study of claims data, a vast majority of copay assistance is used for treatments that do not have a generic alternative, leaving patients without a more affordable option. Meaning many patients who rely on copay assistance programs to assist with the high out-of-pocket cost of their drugs will not have another option to access the prescription and will have to either delay or forego their treatment altogether. And as mentioned, many patients find out when it's too late, and then they're hit with a surprise bill for out-of-pocket costs. Studies have also shown that patients are far more likely to abandon their treatment when out-of-pocket costs exceed $100. This amount could put many Mainers in a position to have to choose between putting food on the table or paying for their life-saving treatment, further stressing families struggling financially during the COVID-19 pandemic. As committed partners in the fight against breast cancer and health equity, we know how deeply important it is for Mainers to receive the necessary treatment that they need. 12 states have already passed similar legislation, and we are urging Maine to be the next state to protect patients and ensure they are not unfairly punished for using copay assistance to help with high out-of-pocket cost. And for these reasons, and on behalf of our patients, we strongly urge you to vote to pass LD 1783. Thank you so much for listening and for your consideration, and I'm happy to take any questions from the committee.
Any questions from committee members for Ms. Katz? Seeing none, thank you for your testimony, Ms. Katz. And next up in favor of the bill is Carol Florman from Cancer Care.
Hello. Can you hear me?
Florman, yes, we can. Thank you.
Sure. Great. Well, Representative Tepler, Senator Sanborn, and distinguished members of the committee, thanks for the opportunity to testify in support of LD 1783. I'm Carol Florman of Edgecombe, Maine, and a policy fellow at Cancer Care, a national nonprofit organization that provides free professional support services and information to help people manage the emotional, practical, and financial challenges of cancer. This is a condensed version of my submitted written testimony. This bill is vitally important to people with cancer, a disease that will strike at least 40% of Americans in their lifetime. Over the last decade, we've seen significant breakthroughs in cancer treatment. These innovative treatments, however, may cost hundreds of thousands of dollars annually. The patient's cost share for these life-saving drugs may be thousands of dollars for a 30-day supply. Many rely on financial copay assistance, which may be in the form of a coupon from the drug manufacturer or help from a copay foundation, such as the one that Cancer Care runs, or another charity. The copay assistance is paid to the insurance company on behalf of the patient, and until recently was treated no differently than if the payment came from the patient's own pocket. This means these copayments counted towards the patient's annual deductible and out-of-pocket cap. Increasingly, however, insurance companies and PBMs are implementing policies that exclude copayments made by third parties from counting towards deductibles and out-of-pocket caps. They require the patient, no matter how many thousands of dollars have been paid on their behalf, to pay their deductible and out-of-pocket cap a second time from their own funds, an obligation that many patients cannot afford. Imagine if someone tried to apply such a policy to another part of your life. Let's say you lost your income due to COVID and needed help with your mortgage. You qualify for an assistance program and your lender accepts the money for your mortgage payment, but then tells you that they've decided not to count that payment towards your outstanding balance. Sounds crazy, right? Yet that's exactly the situation that many people are facing when it comes to their health insurance. These schemes, known by a variety of names, including copay accumulators, allow insurers to double dip by requiring patients to pay their share of costs twice. They also make it extremely difficult for patients to ever reach their out-of-pocket cap, undercutting a critical protection provided by the Affordable Care Act that was designed to keep patients from going bankrupt due to medical expenses. Today, every plan offered on the main ACA marketplace includes a copay accumulator policy. Under these plans, when a patient's financial assistant runs out, and no financial assistant program is unlimited, the patient is back at square one, needing to come up with the full amount of their deductible before their needed drug will be covered. Many patients simply stop their treatments instead. Insurance companies claim that copay accumulators save money by steering patients away from the higher priced drugs, but the reality is that lower priced options often don't exist. And as treatments become increasingly personalized and targeted, substituting drug A for drug B could mean delivering far less effective treatment. Another talking point that insurers use is that copay accumulators ensure that patients have skin in the game by requiring them to pay their cost share with personal funds. Cancer patients already have a great deal of skin in the game, in addition to their substantial out-of-pocket costs not related to prescription drugs, such as transportation to treatment, special diets, childcare, over-the-counter remedies for symptoms and side effects, and salary loss due to missing work. And as for any concerns that this bill would allow patients to circumvent their insurer's formulary to access unnecessary drugs, it's simply not true. Patients will still be subject to their insurance company's formulary and utilization management controls. What LD 1783 would do is restore a fair and common sense world in which a payment made to an insurer, regardless of its source, is counted towards a patient's cost-sharing obligations. To date, 12 other states have passed laws banning copay accumulators. I urge the members of this committee to join them in supporting cancer patients and their families by voting in favor of SP 621. I'm happy to take any of your questions.
Are there any questions from the committee for Ms. Florman? I have a brief question for you, Ms. Florman, since no one else seems right now to be speaking up. I was concerned when you said that these are sometimes known by other names than copay accumulator. And I'm wondering if in using that terminology in her bill, Senator Sanborn is missing any opportunity to protect consumers that you can note.
I think it would be important to include a discrete actions because it's really any, because they can call, I mean, there are some really crazy names out there that actually, you know, even will say like co-payment protection benefit. I mean, so they're really twisting words to try to come up with different names for this. So I think it would be very important to describe that third-party payments or coupons or anything that is paid on behalf of a patient toward their co-payments be counted toward their deductible and toward their out-of-pocket maximums.
Thank you. I believe actually that the bill does include a description. So I guess we've got our bases covered. It's just the title that uses the term.
Yeah, and I think we'll continue to see you know, more terms applied. And of course, they're also very hard to find in insurance plan documents.
All right, seeing no other questions, thank you very much for your testimony. And moving on to others speaking in favor, I see that Hillary Schneider has already joined us from ACS Cancer. Hillary, please go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee. As you know, my name is Hillary Schneider. I'm the Regional Director for the American Cancer Society Cancer Action Network. On behalf of ACS CAN and our constituents, many of whom have been personally impacted by cancer, we thank you for the opportunity to provide this testimony and urge your support of LD 1783. I'm going to just summarize my testimony. As you've heard, many cancer patients have difficulty affording the cost of their prescription drugs, regardless of whether they are insured. This is especially true for newer drugs that do not yet have a generic equivalent. As you heard me talk about earlier today on the bill related to affordability, according to ACS CAN, a national survey that we conducted last fall, 61% of cancer patients and survivors find it somewhat or difficult to afford their care. Over 60% of cancer patients and survivors face challenges and have taken steps to reduce prescription drug costs. Of those, 28% have used a drug manufacturer's coupon or assistance program. In addition, it might be important for you to have the data from the survey around 80% of cancer patients and survivors have taken steps to address the cost, with 44% taking money out of their savings and 36% accumulating credit card debt. A third have not filled a prescription in order to reduce costs. So as you've heard from me many times, affordability of health coverage is really important. As you've heard, copay accumulator programs can get in the way of that, resulting in patients experiencing increased out-of-pocket costs and taking longer to reach required deductibles. Such utilization management tactics negate the intended benefit of patient assistance programs and remove a safety net for patients who need expensive specialty medications but cannot afford them. This can lead to poor health outcomes and potentially higher costs to the entire healthcare system. Moreover, copay accumulator programs often lack transparency and are often implemented without a patient's knowledge or without a patient fully understanding their new quote-unquote benefit. However, with the implementation of LD 1783, barriers to copay assistance would be removed by requiring all payments made by patients directly or on their behalf to be counted toward their overall out-of-pocket maximum payment or deductible. Requiring health insurance carriers to do so will protect cancer patients from surprise bills and treatment delays, as well as allowing individuals to utilize the full benefit of copay assistance programs. And for these reasons, we urge you to vote ought to pass on LD 1783. Thank you.
Thank you very much, Ms. Schneider. Are there any questions from the committee for Ms. Schneider? Seeing none, I have Laura Harper on my list as well, also from ACS CAN, but she doesn't seem to be in the room. So Hillary.
Yeah, it was just in case I was not available. We were told to both register. Thank you. I appreciate it.
Okay. So is there anyone else in the meeting, on the call, who would like to testify in favor of LD 1783?
I think just Ann Willison. I'll bring her in.
Okay, thank you.
Here she comes finally, I think. There we go.
Good afternoon. I just want to make sure people can hear me and maybe see me.
Now we can see you and hear you. Thank you, Ann.
Hi. Hello, Senator Sanborn, Representative Tepler, and other distinguished members of the Joint Standing Committee on Health Coverage and Insurance and Financial Services. Great to see you today. I'm Ann Willison, Executive Director of Consumers for Affordable Healthcare. And as most of you know, Consumers for Affordable Healthcare is a Maine-based, nonpartisan, nonprofit organization with the mission to improve access to affordable and quality healthcare for all people living in Maine. Despite concerns we have about the impact coupons have on rising healthcare costs, I am here today to testify in support of LD 1783. As you've heard, the bill requires health insurance carriers and the pharmacy benefit managers to include cost-sharing amounts paid on behalf of an insured when calculating the insured's contribution to any out-of-pocket maximum deductible or copayment in certain circumstances. Again, while we have concerns about the role coupons play in increasing overall healthcare costs, we believe this bill takes a reasonable approach to providing some relief to Maine consumers who have high out-of-pocket healthcare costs, especially those with chronic conditions and individuals and families with low income who do not have sufficient resources to meet large deductibles. Individuals and families with chronic conditions and high deductible plans have higher levels of financial burden than those in traditional plans. Health Affairs has discussed studies regarding the impact of out-of-pocket spending on these families, indicating that almost half reported problems paying medical bills and other bills due to healthcare costs. Having just one chronic condition has a huge impact on out-of-pocket spending, two conditions even more. Enrollees in high deductible plans are also more likely to stop taking their medication for a chronic illness. I talked about the American Cancer Society survey, which Hillary Schneider just talked about, so I won't spend a lot of time on that. But do want to bring attention, to the fact that while prescription drug coupons may alleviate high out-of-pocket costs for some individuals, research has shown that they can also increase overall healthcare costs by steering people away from inexpensive generic alternatives. I did want to bring your attention to one study that compared coupon use in New Hampshire to coupon use in Massachusetts, which banned coupon cards for drugs with a generic equivalent, but that allows it for drugs with no generic competitor. The study found that the coupon restrictions in Massachusetts actually led to higher use of generics, which in turn, the researchers believe saved a substantial amount of money. This bill includes safeguards that allow for coupons to provide relief to individuals struggling to afford medications that they need, while also preventing coupons from artificially inflating demand for expensive prescription drugs. Coupons can contribute to higher healthcare costs when they incentivize an individual who would otherwise get a low-cost generic or a cheaper alternative drug to instead purchase a more expensive brand name drug. However, if someone needs an expensive brand name drug, then making it more affordable does not artificially increase the demand for that drug or unnecessarily drive up healthcare costs. We should not strive to lower costs by limiting access to life-saving treatments or other medically necessary care. We know that improving access to medically necessary healthcare treatments and prescription drugs can lead to improved health outcomes that can result in long-term savings by preventing or reducing the need for more expensive medical care later on. I go on to talk about people who truly need access to expensive brand name drugs, and anything we can do to help shoulder some of the out-of-pocket costs in these situations when expensive drugs are truly medically necessary can reduce affordability barriers to accessing medical treatment and help to alleviate medical debt and other financial burdens resulting from accessing expensive care. For these reasons, we do urge your support of LD 1783. Thanks for listening to me after a long day, and happy to answer any questions.
Any questions from the committee for Ms. Wolfson? Seeing none, thank you very much for your testimony. And I will ask once again if there is anyone else in the meeting who would like to testify in favor of the bill to please raise their hand. And seeing no hands go up, I will switch to those who wish to testify against, calling up first Mr. Garrity. Go ahead, Mr. Garrity, we can see you.
Thank you, Representative. Senator Sanborn, Representative Tepler, and members of the committee, my name is Bruce Garrity, and again, I'm testifying on behalf of the Maine Automobile Dealers MEWA program. We are opposed to this bill for several reasons. I understand the motivation behind it, and certainly keeping prescription costs down is something that this committee has focused on for several years now, and certainly is one of the significant cost drivers that everyone is trying to address. We are concerned with this bill for a couple of reasons. First, especially with couponing, as I understand it, that's often used by pharmaceutical companies ostensibly to cover some deductibles and copays, and then the assistance goes away, and at the same time, the pharmaceutical company is getting its money back in terms of the overall payment for the drug and getting paid back its coupon directly by the pharmacy. So essentially, it's a circle that works to the benefit of the pharmaceutical companies and increases costs overall. Second, our concern is that for the most part, plans use various step therapies and other programs to try and keep costs in line for every participant in a plan that has drug benefits. We think this can serve to skew that and end up increasing costs for other people. There are valid reasons not only for copayments and deductibles, which this committee has discussed at length, and I don't need to go into here. And I think things that upset that balance are things that the committee needs to look at very closely. I would point out that, and I'm checking with the plan right now on how it handles all of these situations, but as a practical matter, our goal is to try and keep costs down for all our members. We don't have a profit motive. We don't have any desire to charge more than whatever the actual premium is required. So we are not in a position where trying to avoid giving people benefit for the plans they have available or the opportunities they have available is something we're looking to do. Pardon me. The other concern we have is that under this legislation, if someone, if it were to pass, if someone is already on a name brand drug and then they move to this program, they're going to get to stay on the name brand drug, even if a generic alternative is available. That's something, if the committee decides to move forward with this legislation, it definitely should address. With that, Representative, I would be happy to try and answer any questions the committee might have.
Thank you, Mr. Garrity. I think you may want to take a look at the bill again, because I believe that it only permits the coupons for bills with no generic equivalent.
What it does allow, I thank you for that comment, Representative. What it does say, I believe, is that the person has access to the name brand drug. They get to stay on it, even if after that a generic equivalent is becomes available. If I'm mistaken in that, I apologize, but I think as a person moves forward with care, when generics become available, that has to be a factor, and that's where you tie into step therapy.
I think that it would be the intention of the committee to deal with that question as we move along. So thank you for that, Mr. Garrity. But I will ask other committee members if they have questions, but I also have one. So I guess I'm confused by the auto dealer MIWA's opposition to this bill because they don't have a copay accumulator program.
That's a point that I'm checking on. I do know this, to the extent that a situation exists where the person isn't using their deductible, and at the same time the money is going back to the pharmaceutical company through the couponing process. We certainly oppose that, and we certainly aren't going to. In our view, that shouldn't be applied against a copay or a deductible.
I'm sorry, I think I'm confused, but I may need to understand this a bit better before I ask more questions. Does anyone else on the committee have a question for Mr. Garrity? Seeing none, thank you for your testimony. We will move to the next person speaking in opposition and bring Ms. Pelletreau into the committee room.
Good afternoon, Representative Tepler, Senator Sanborn, members of the committee. My name is Catherine Pelletreau. I'm speaking for the Maine Association of Health Plans in opposition to this bill. We feel that this bill takes the wrong target to address the high cost of drugs in our society, I guess, in our healthcare environment. And it undercuts health insurance. This bill is not about whether coupons are a good idea or a bad idea, but they're about how coupons get applied. For the committee's information, there are incredibly strong arguments against coupons. In fact, they have been banned by Medicare. They have been banned by Medicaid. The IRS has issued guidance saying that they cannot be used for HSA plans. You will see citations for these in my written testimony that you already have. So this bill is not about whether they should exist or not, but how they should be applied within a health insurance product. And health insurers are not crazy about coupons. but they've learned to live with them. In fact, many of our members actually try to connect members with those coupons so that they can get the benefit to the copays. But they do it in such a way that it does not apply to a maximum out-of-pocket expense, does not apply to a deductible, but it does help with their copay. So as you heard from previous speakers, and I want to reiterate here, even though coupons can help some individual consumers, they have an overall negative impact on the cost of health plans. And a program that, such as what is being proposed here with this bill, essentially would require health plans to treat a tool that manufacturers use as a substitute for consumer cost sharing. It subverts the actuarial value of a plan, and it speeds people to, especially people with really high cost specialty drug coupons, into 100% plan paid status quickly. Remember that the highest drivers of actuarial value are deductibles and maximum out-of-pocket expenses. So these accumulator adjustment programs that do exist with carriers, I do believe that all of our carriers use them. They allow copay assistance to be used and patients to receive the benefit, but they ensure that the patient's actual out-of-pocket spending is accurately represented. So the patient is still obtaining their medication at a rate that's negotiated by the plan with the manufacturer, which is typically lower than the list price, even if the cost-sharing assistance is not counted towards the out-of-pocket limit. So these programs protect the entire risk pool from the market manipulation and higher costs that are caused by copay assistance programs. Now, because the commercial market is the only place that these coupons can be used, there's aggressive pushing of these kinds of bills all over the country. We would posit that a better approach is to address the root cause, which is the list price of the drug, rather than relying on these, coupons from a manufacturer or other kind of manipulations. I think I'll stop there. We urge the committee to oppose this bill for the reasons that we've outlined. And I thank you for your consideration and happy to take any questions.
Are there any questions from members of the committee for Ms. Peltro? I do have one, but I'll hold off for others. Go ahead, Heidi.
Yeah, I was struck earlier. Oh, sorry. Oh, sure, no problem. I was struck earlier in the testimony from some of the proponents of the bill and some of the bill text as far as for medications that don't have a generic equivalent at this point, that is what this would count for. So that in my mind, if somebody has is particularly something like a lot of illnesses, but like, let's say cancer, for example, and there's a medicine that could help with treatment in that realm, that it could help, it also could help limit costs, and also as well as preventing some further pain and suffering. And also the with the coupon programs, I was also struck by the testimony as far as comparing it to like a mortgage payment. Like if there was help with paying a mortgage, it's almost like double dipping to count it against, not count it within is going towards a deductible or some sort of cost sharing. So those are some things that are going around in my mind, and it seems pretty compelling that that something like this, although I would love it if we had more affordable medications and that we would have a system that promoted overall early diagnosis, prevention, treatment more so than it does now. We have great strides, but we have a ways to go in my mind. But I think that there's a balance too about cost, overall cost in healthcare. And also I'm struck by the rebate system. And it seems a little bit akin to rebate systems, although a different mechanism. So I just don't know if you have any more insight into that, or if you could bring some more, I don't know, some more measurements where this actually takes place within patients, like the coupon programs, and how this might have compared to when or in cases that maybe a coupon program doesn't offset what would go towards a patient's out of pocket. So I don't know, that's kind of a big thought or question, but I don't know if you could take a stab at it, or maybe during the work session if you had any additional thoughts.
Thank you for that question. I agree there was a lot in there, and I can't respond to all of it, but I would make a couple points. First is, remember that the coupon assistance that comes from a manufacturer is entirely under their control. So they can decide who they issue the assistance to. They decide which drugs they want to issue the assistance on. It's not as if it goes to all their drugs or every patient on their drugs. It's that's in part why I hesitate to use discriminatory, but maybe unfair. Maybe it's unfair. So I think it's important for the committee to understand that this is not like a universal access to copays, that anybody who gets on an expensive brand name medication automatically qualifies. In fact, from what I've heard from my plans, what can happen is, it's unfair in the sense that some patients get it, some patients don't, and some patients get it for limited periods of time. And certainly they stop getting it as soon as, the health plan is paying 100% of the cost. So it's a way of keeping some of the highest cost, keeping health insurance paying for some of the highest cost medications, rather than being able to have people try less costly medications, even if they're not generics. I know that the bill has a protection around generics, and that's great. And I think Senator Sanborn even mentioned that there was some willingness to expand that provision, which I also think is a good idea. So we'd love to work on any amendments like that. But Representative Brooks, that's a little bit, and I will work on getting some more for you.
Thank you, Ms. Peltro. And now I see Representative Arford has a question as well.
Right. So there's definitely clearly at least two issues here. There's the issue of whether or not a coupon is a good idea and all those reasons behind that question, which you were just somewhat addressing. But I was seeing, my understanding of this particular piece of legislation is the policy issue is simply whether or not someone who has a coupon, whether or not it's fair, just, whatever, however they got it, they have it. And when they pick up their pharmaceutical product, they use it to pay part of their copay. And so the policy question is whether or not that part that they pay using the coupon should be added to their deductible accumulator and be used to pay down on their deductible. And if they're not allowed to do that, then are they not in fact being double charged? So my question to you is, I'm not really understanding, and I do appreciate all the information you've given us, by the way, it is helpful, but I don't really understand why the insurers would oppose specifically that part of this bill on just that one policy of allowing the patient the part that they pay, because they're still paying it. The insurer is not paying it. The patient is paying it using their coupon. Why they are opposed to allowing the patient to do that and have it count towards their deductible.
Yeah, I mean,
Okay.
it undermines the integrity of a health plan. I mean, just for one thing, Representative Arford, when a coupon is used at a CVS or a Walgreens or something like that, the coupon, the value of the coupon goes back to the manufacturer of the medication. The coupon itself is not worth money to the health insurer. So that's one issue. Okay, the coupon is not actually money for a health insurer. It's different than if you went to a CVS and you had to pay $100, out of pocket versus $50 and a $50, copay coupon. I mean, the health insurer might never even know that you used the copay coupon. It doesn't flow in an insurance system the same way that your out-of-pocket expense does. So that's one. And then the other is, I just reiterate that, health plans are built, they're rated using predictions of how many services somebody is going to use. And it's not for an individual, but it's over a whole population. That's what an actuarial value means. For a bronze plan, it's about 60% across the whole population of a plan. That a health insurer would be paying 60% and consumers would be paying 40% as a group. So when you have these copay, these coupons, what it does is accelerate the pace at which somebody burns through their deductible and maximum out-of-pocket expense. So it accelerates the pace at which the health plan then has to incur 100% of the cost for that medication. So that's why it's a problem for health insurance. And that's why when those additional costs hit, and as you've heard, it's so often for the really expensive specialty drugs that don't have an alternative out there, it throws off the actuarial value of the whole plan and raises premiums for everybody in there. Everybody who's purchasing. So.
Thank you.
All set, Representative Arford? Yeah. Ms. Peltro, can you tell me, do you believe that all of the copay assistance programs are designed solely for market manipulation, or are any of them actually going to help low-income folks afford their medications?
Of course they're attractive, if that's what you're really asking. I understand the rationale for them entirely. And I do think that they help with, cost shares. That's why in my testimony, I mentioned that health insurers, they may not like coupons, but they see how important they are for their members. And so they will actually try to connect people with coupons. They'll try to connect their members with additional resources out there. But that doesn't mean that they're counting all of that towards the maximum out-of-pocket expense or the deductible. So I think what you were getting at is if I cynically believe that there's 100% market motivation, and I would say no, I don't. I think that they are helping people, and that health insurers, see that they're being used. But we would draw the line at needing to, we would draw the line at the subversion of the integrity of the health insurance product. So that's kind of where our line is.
Okay, thank you, Ms. Peltro. I do have a question that I'd like to have some information on for the work session, Ms. McCarthy-Reed. I need sort of a map of the monetary flows with coupons. So I need to understand where the money is coming from that pays for the coupon to begin with, where the coupon is used who is paying the difference, and how that could or could not affect someone's copays. So I just need to more fully understand that monetary flow. Thank you. So yes, Representative Evans, you have a question?
Yeah, thank you, Madam Chair. Ms. Pelletreau, you just mentioned the subversion of the insurance product. Can you expand on that? What do you mean by that?
Sure. You know, our concern is that a health plan is built on assumptions. It's built on assumptions about, you know, what care people are going to use, how much that care is going to cost across a population. It does not account for whatever, you know, third parties are going to offer in coupons on whatever drugs they're going to be offering that year. And the problem with the coupons and applying them to the deductible and the out-of-pocket expense is that it burns through the deductible so that the health plan is having to pay 100% of cost faster than they would have absent the coupons. So the coupons aren't a part of health insurance. They're something else. You know, they're developed by manufacturers. I even think that we have a health plan who's issuing a few coupons themselves, but it's not part of an insurance product. It's assistance that's coming from somewhere else in an unknown set of circumstances. So for certain patients, for certain drugs, not all patients, not all drugs, it's not part of a health insurance product. I don't know if that's helpful.
Are you set, Representative Evans?
Yes, I am. Thank you, Madam Chair.
Okay. I have sort of a follow-up question, Ms. Pelletreau. So if I had a wealthy relative, let's say an elderly aunt, who decided she would help me pay for my medications and who gave me some money so that I could pay for my medications at the pharmacy, would that subvert the health plan design?
That's a different scenario, Representative Tepler. If you were getting cash from somebody, you would come in and you would pay that cash. And it's like oftentimes parents will pay on behalf of their children. I feel like I do it all the time, you know? So that's a different scenario than a coupon that's issued by a manufacturer where the value of the coupon goes back to the entity that issued it.
So that, I guess I'm confused about that, because when I use this coupon in the supermarket to buy butter, let's say, the producer of butter makes sure that the supermarket's cost is covered for that. So are you telling me that the pharmaceutical companies are not covering the pharmacy's costs for the medication with the coupon?
I mean, I would welcome you to talk to a pharmacist for their perspective, but my understanding, and I will confirm it, is that when you go to a CVS or a whatever, you know, place you're picking up your prescription and you use a coupon, the coupon, you know, it doesn't go to the value of the coupon doesn't go to the health insurer. It goes to the issuer of the coupon. You know, this is after a patient has used it to pay for something. It's not the same as cash.
No, but that's coupons used in other circumstances don't work that way. So that's why I am very confused.
I think I'm confused as well. And I will come back to you.
Okay, thank you. So are there any further questions for Ms. Pelletreau? Seeing none, thank you very much for being with us and being patient with our questioning.
Thank you.
And I will turn next to Mr. Hollemeyer, who is also testifying in opposition from PCMA. Welcome, Mr. Hollemeyer.
Thank you, Madam Chair. Good afternoon, everyone. My name is Sam Hollemeyer. I am Director of State Affairs on behalf of PCMA, the Pharmaceutical Care Management Association. I appreciate the opportunity to speak to you all today, Madam Chair Sanborn and Madam Chair Tepler and members of the committee, to oppose LD 1783. PCMA is a national trade association representing America's pharmacy benefit managers, otherwise known as PBMs. I did submit written testimony today for this bill, but I wanted to share some key points. Again, LD 1783 would require the use of third-party payments to apply towards a patient's out-of-pocket, deductible, or co-payment. And we confirm that these third-party payments are typically referring to the use of drug manufacturer coupons. As it was shared previously, these coupons are a marketing strategy used by the manufacturers to steer insured patients to more expensive brand name drugs instead of an equally effective, more affordable brand alternative. Typically, when there's competition in the drug marketplace, the consumer wins. My member companies, the PBMs, can pit these drugs up next to each other to get to the lowest net cost for overall better formulary placement. At the same time, though, we find that coupons only exist when there is competition between drugs, only to steer patients towards certain brand name medications. This steering undermines the PBM's ability to get to that lowest net cost, which then raises costs for all consumers. As was shared previously, these drug manufacturer coupons are banned in federal programs such as Medicaid and Medicare, and also military and veteran health plans, as they are considered unlawful under the federal anti-kickback statute. In my written testimony, I do have some dollar amounts outlining the additional costs that these coupons do incur. It was also shared that the IRS, an additional handout that I shared with you all, has stated that third-party payments cannot be counted towards a patient's deductible if they're in an HSA. It was shared that coupons decrease costs for patients. While this might seem true at the pharmacy counter, they raise costs overall over the board in the form of premiums. Additionally, I don't think it was shared previously, but these coupons are typically temporary. The individual patient will then pay more when the coupon goes away instead of being started on the formulary drug, the cheaper drug from the start. Ultimately, it's the manufacturer and not the patient who benefits by forcing the plan to pay more for the expensive drug. If the drug companies were so concerned about consumers accessing medications, and instead of offering coupons, they should just lower their prices. Yet they have found it is more profitable to offer coupons instead of lowering the price. It is for these reasons I stated that LD 1783 is concerned for us, and we are opposing it in Maine, and I'm happy to take any questions at this time. Thank you.
Thank you, Mr. Hollemeyer. Any questions from the committee for Mr. Hollemeyer? Yes, I see Representative Brooks. Go ahead, Representative Brooks.
Yeah, I had one question. One thing that I've also seen might be a significant benefit to coupons is similar to when, one benefit I could see is when a patient has, there's no generic available, but the doctor and patient come to the provider and patient come to a understanding that this medicine could be helpful, whatever the medicine may be. And I think there are a lot of cases where whatever the medicine is, there's kind of a trial period where a patient starts a medicine and for whatever reason, either the medicine might be intolerable, maybe via side effects if they don't subside over time, or maybe it doesn't have the desired clinical effect. And then maybe a temporary couponing program might help that initial phase. And I don't know if you can speak to that, or you could, if you have any information about how often does a patient try any medicine and need to switch before they find the right match for them.
Thank you, Representative Brooks, for the question. I'm afraid I am unable as a non-clinician to answer that. There's so many various disease states and the relationship between doctor and patients on getting on the right drug. I don't know if I'm the appropriate person to ask or answer that question. I can certainly take it back and find some information, but I'm not familiar with temporary coupons either, but I can certainly take it back and get some information for you. Thank you.
Mr. Hallmeyer, I have a quick question.
Sure.
If under this bill, coupons only apply in accordance with the formulary, are you still in opposition?
I'm sorry, can you repeat the question back? I'm not sure I'm following.
So if under this bill, coupons can only be applied within the formulary, are you still in opposition?
That's an interesting question because the way formularies are structured, there's usually generic, it's tiered. So there's generics, there's preferred brands and non-preferred brands. I guess we could see an example of a coupon being used on those non-preferred drugs, which are typically higher cost for the plan. That's a good question though. I'd be happy to take it back and take a look at it, but I don't have a reaction right away, but I can certainly take a look at it. But as far as the tiers are concerned, that would still be an area of concern for me, but I can certainly take it back.
Yes, I would appreciate that. Thank you.
Sure.
Any other questions from the committee? Seeing none, thank you for your testimony, Mr. Hallmeyer. I just muted myself. Whoops. And now we will turn to, there's one more person who is, I'm sorry. Yes. Chris Ossenfort, Ms. Ossenfort would like to testify in favor. I mean, in opposition. Excuse me. I'm sorry, Ms. Ossenfort, I got that one wrong.
It's okay. I spelled my name wrong when I signed up to, so. Good afternoon.
It's all the pandemic, ma'am. It's all the pandemic.
Good afternoon, Representative Tapler, Senator Sanborn, and members of the committee. My name is Ford, and I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield. And I appear before you to testify in opposition to this bill. We would reiterate the concerns. I think even proponents of the bill noted that there can be adverse consequences from prescription manufacturer coupons that can result in higher costs. It does encourage the use of higher cost drugs, and it essentially helps some people out at the expense of others. And as this committee is well aware, insurance is a balancing act of trying to balance benefits and affordability. So we would suggest that if you are interested in this, like other states, you could study the impact and determine whether or not you think it's advisable. I would note that there are distinctions between manufacturer coupons, and I think Representative Tepler, you were touching on this before, and other sort of means-based patient assistance programs. Our concerns are focused on manufacturer coupons rather than some of the other patient assistance programs. And I think that if the bill were applied to formulary, I think we would still be concerned about it because it still could encourage someone to use a higher price drug over a lower price drug, even when both are on the formulary, and also the provisions of the bill that would allow coupons if there's been prior authorization approval. Sometimes prior authorization does apply to non-formulary drugs because there isn't a drug on the formulary that works for the individual. So I'll be happy to take that back, but I think that we would still be concerned about that. With that, I will be happy to answer any questions, and of course I'll be at your work session as well.
Thank you, Ms. Ossenfort. I guess I need to ask you the same question we asked Ms. Pelletreau. Do you believe that all of the manufacturers' coupon programs are designed for market manipulation, or are any of them actually designed to help people pay for their medications?
I think there's a difference between means-based assistance programs and manufacturer coupons. I do think that manufacturer coupons are largely designed to manipulate the market and influence the prescribing of higher cost drugs.
Okay, thank you for that. Are there any other questions from the committee for Ms. Ossenfort? Seeing none, thank you very much for Oh, yes, there's one more quick question. Ms. Austin-Ford, do means-based programs count towards deductibles?
I will have to check on that off the top of my head. I don't remember, but I will check on that and get back to you.
Okay, I think that's going to be a pretty important question for this bill and this issue. Thank you. All right, so I think we've heard from all of the folks who are going to testify against, unless there's somebody else in the meeting who would like to testify against it. If so, please raise your electronic hand right now. Seeing none, our final testimony for the day will come from Mr. Yardley of the Bureau of Insurance. Welcome, Mr. Yardley.
Good afternoon, Representative Tepler, Senator Sanborn, and distinguished members of the committee. My name is Ben Yardley. I'm senior attorney at the Bureau of Insurance, and I won't read our testimony. I think the issues have been laid out thoroughly. I'd say that there was mention earlier that a number of other jurisdictions have enacted copay accumulator laws. The issues under study at the NAIC, which has not yet taken a position. And it's my understanding that is scheduled for discussion in early 2022. That would be this year, now that I've caught up. We would be glad to if there are developments at the NAIC, bring them to the committee's attention. With that, I would be glad to try to answer any questions now or bring back answers at the work session. Thank you.
Thank you very much, Mr. Yardley. We appreciate you being here, and I forgot to mention that you are testifying neither for nor against the bill.
I forgot to mention that too.
But now we know. Are there any questions from the committee for Mr. Yardley? I think we're going to need some lessons in how all of this works and how all of it flows for our work session, Mr. Yardley. So it would be helpful if we could have some assistance from your department in doing that as well as Ms. McCarthy-Reed.
I will get the people together and we'll try to come up with something for you.
Thank you very much, because it's important to understand for us, I think, how to help low-income Mainers with the high cost of particularly some medications that are don't have generic equivalents and are on the formularies or at a high tier on some of the formularies of our insurers, but yet might be necessary to help fight cancer. So the new biologics and that kind of thing is particularly, I think, what we're thinking of. So any other comments or questions from the committee? Seeing none, we will turn and ask if there's anyone else who would like to testify neither for nor against this bill. Please raise your little electronic hand. And seeing none, I will close this hearing, and that ends our work for the day. Do you have any announcements, Senator Sanborn or Ms. McCarthy-Reed?
I don't. I'll see everybody on Thursday.
Yes, we will reconvene Thursday morning. We have a series of confirmation hearings and a report from the Bureau, I believe.
Not Thursday. Thursday is additional public hearings. The
Okay.
confirmation hearings are next Tuesday. So
sorry, getting my
more
dates
hearings.
mixed up.
Yep.
Thanks, Colleen. I mean, Ms.
I suspect our day will be considerably shorter on Thursday. So just for the committee's peace of mind, today went longer than I expected, but I don't think Thursday will.
All right, everyone, take care.